We now will begin the first module of the day, featuring experts from the Baptist Health Miami Neuroscience Institute. You saw in the video the leader on a scooter of the M&I, but Dr. Tolchin will guarantee he took away that scooter, right? He's not allowed to use it anymore. So, the panel will be moderated by Dr. Ronald Tolchin, Chair of the Non-Surgical Spine Care and Rehabilitation, and the Irma and Coleman Bass Endowed Chair in Pain and Rehabilitative Medicine. Dr. Tolchin will be joined by Dr. Raul Vasquez-Castellanos, Director of Complex Spine Surgery, Dr. Guilherme Dabus, Co-Director of Interventional Neuroradiology and Director of Fellowship Training Program, Dr. Vitaly Seelman, Director of Cerebral Vascular Surgery and Epilepsy Surgery and Co-Director of Skull-Base Surgery, Dr. Evan Bander, Director of Endoscopic Skull-Base Surgery and Co-Director of the Pituitary Tumor Program, Dr. Justin Sporer, Director of Functional Neurosurgery, and Dr. Luis Felipe Torres, Director of the Epilepsy Program. Doctor.
Good morning, everyone. It's great to see such a great crowd out here, and welcome to our International Symposium. I am Ron Tolchin. I'm going to be your moderator today. I'll try to keep us on track. And I am just, I've been at Baptist for a little over 12 years. I'm the chair of non-surgical spine and rehabilitation. And I've been so blessed to be around a great group of colleagues of mine, some of whom you're going to meet this morning. As Alex Velosh mentioned, that we are ranked 39th in the nation for neurology and neurosurgery, and it's a great accomplishment under the direction of Dr. Michael McDermott, who you did see on a scooter. After breaking both wrists, he learned very quickly not to do that anymore, and now he's got a golf cart. So I'm going to move on and introduce our first speaker. You're in for an exciting morning, let me tell you. We have our world-class speakers here. All of them are nationally known in their areas of expertise, and just a pleasure to work with. And you'll see really great lectures from them, and I'm so excited to share that with you. So our first speaker today is, I've known Dr. Raul Vasquez for the past almost 6 years. He is our Director of Complex Spine Surgery at Baptist Health. He specializes in the surgical treatment of complex spinal disorders, tumors, degenerative spine, scoliosis, and other spinal deformities, revision surgeries, and also some neurotrauma as well. But he came to us from the University of Puerto Rico, where he trained for his medical school and then did his residency in neurosurgery at University of Florida. So he's a Gator. We have a couple Gators here today. And maybe you coming from outside the country don't know what that is, but it's the alligator mascot for the University of Florida. It gets very big down here with University of Miami fans and Florida State fans. It's really very, very controversial. And then from there, he did his postdoctoral training, including 2 fellowships, one a clinical research fellowship at the National Institute of Health, and then a second one in complex spine surgery at Vanderbilt University in Nashville. And before joining us, he worked in Kentucky. So he's been all over the Deep South, finally ending up here in South Florida. We're so happy to have him. He serves as an editorial reviewer for several journals in neurosurgery. And he's nationally known and invited speakers all over the country and even outside the country. And he's part of a number of neurological associations and societies. So it's with great pleasure that I introduce my colleague and friend, Dr. Raul Vasquez.
Good morning. Bienvenidos. So today I'm going to talk a little bit about what we do every day and in terms of in the world of complex spine neurosurgery, scoliosis surgery, and the new paradigm shift that we're doing in what we call the medical decision making. We have reached a good advancement in technology, especially here at Baptist, with neuronavigation, computer, robotic surgery, but we have encountered some challenges when it comes to the medical decision making. have no disclosures. The objective of this talk is to get an overview of the spine care, understand the pathophysiology of what we do, scoliosis, spinal pathology. I will talk a little bit about scoliosis, what we call post-laminectomy syndrome, patients that had failed back surgery and need a revision surgery. And we're gonna introduce the new concept that if anyone talking about spine in the world right now, in all the meetings, are talking about now biological age, biological resilience, and the impact on duration of symptoms when it comes to determine to do surgery on a patient. So why spine care is the incidence is extremely high. We all, at least at some point, is going to have an episode of back pain in our lives due to an injury or degeneration. It's very prevalent, and the incidence is high and keeps going higher as the population is aging. It costs a lot of money. It's at least number 2 most visit to a doctor after a common cold, and is one of the main source of disability. And it costs a lot of money. So the spine is a complex 3D mechanical structure, and we can go into the details of the anatomy. Is the core of our stability, our independence, and walking. The biomechanics of the spine is very complex. It's a living component of organ with different forces, muscle, that is influenced by the gravity. The different regional anatomy have different biomechanics, and that's why when we talk about spine, we evaluate patients come, I just have back pain. It's like, why are you checking my neck or my arms? Because it's all interconnected and related. Most likely, if you have severe degeneration in your lumbar spine, there's some pathology undergoing in the cervical, and it's very common. The causes, we know they could be anywhere from trauma, from cancer, or just disc degeneration. The bulk of what we do here at Baptist, and when we come to spine care, it relies on decompressing the nerve, stabilizing the spine, and it is interesting because different from cancer, this is a quality of life decision most of the time. No one's gonna die from a sciatica pain, but they're not gonna be able to ambulate or walk independently. In the U.S., the number of spinal fusion has increased dramatically in the last 20 years. Number one because of access to the care, and also because of the technology and the amount of trainees that we have in both orthopedic surgery and neurosurgery. I'm a neurosurgeon, brain and spine by training, but I also, part of my fellowship included some orthopedic training. So we have reached now that combination of both specialties, and it comes to the part of treating the spine by decompressing the nerve and stabilizing the spines with rods and screws and fixation. In order to understand this spinal pathology, we need to understand the physiologic processes, the structural biomechanical components, and that way we can understand what the patient is feeling, like how they're feeling in terms of the pain, the disability. Understanding the disability that a patient is undergoing could be more important than just understanding the images. So it requires a complex understanding of this organ that we call the spine, and this is a representation. The specific problems, like I mentioned, is most common degeneration of the disc that leads to a radiculopathy, to a stenosis, both lumbar, cervical, thoracic, tumor, and even emergencies. I like to put this representation here on the screen because it's kind of like, this is aging is not a disease. I mean, we're all aging. Sorry to tell you, and this is all going to happen to us. I mean, it's and my talk is going to be both about complex spine, but we're going to talk about aging, and because that's what leads to the pathologies in the spine most of the time. The classic radiculopathy, the sciatica, and coming from someone that had once a herniated disc in the neck is very disabling. Even the amount of pain, not able to sleep, I mean, it's a big source of disability. Then as we keep aging, then we have the nature of the stenosis and the classic shopping cart sign, right? Like we call it neurogenic claudication that leads from the lumbar stenosis. So how we go from the left to the right, so there's a patient that had like two surgeries before. She persisted with pain, a lot of sciatica, disability, inability to walk, and then we go and do a definitive correction. The patient selection, I mean, we see anywhere from 30 to 45, 50 patients a week in consultation. I see a lot of international patients. Somehow I became the Casa de Campo neurosurgeon. I'm Dominican, but I grew up in Puerto Rico. So. And we see these every day. So how that happened, how to decide you are a suitable candidate for surgery or not. So when it comes to adult spinal deformity, the risk assessment tools is something that kind of like you grab to it, you hold on to you get anything that you can to help you make that decision, because it's not uncommon, right? Like we see that every day from a thyroid disease to a surgery, the patient that you do exactly the same, one do well and the other doesn't. So how we select this patient and how we determine that a patient is candidate or not for these kind of operations. We have different assessment tools. The more classic one is the ASA, is the American Society of Anesthesiologists score. There is another comorbidity index, the Charlson. And then we have got now to the point of developing predictive models based on quantifying complication risk and spine-specific outcomes that can predict pseudoarthrosis, proximal junctional kyphosis. Pseudoarthrosis is when we put all these rods and screws and the spine doesn't fuse together and they become loose. So we can predict that using different modalities, so checking the bone density scan, checking your vitamins, your bone health, and your biomechanics. Then that has not been enough. We go to determine what we call a frailty score. So we determine the ability of that patient to withstand a big surgery or any surgery based on their physiological reserve. The challenges that we have encountered with this is these all depends on a chronological age. And then how we explain that not every 70, 65, or 60-year-old person is the same. How we explain that beyond just the chronological age. We see that every day, right? The 80-year-old that is running a marathon and the 50 that can't. So how we explain the reserve and just beyond that chronological age. So those questions are becoming more demanding in the setting of an aging population. And age became more than just a number. So that comes to us, and this is the main message of this talk is we have to rely on the genetics. Telomere is the tail end of our DNA. We have gone into significant research, especially coming from UCSF and Stanford, the association of that genetic material, the telomere, with the risk of complication in adult spinal deformity surgery. Based on the length of that telomere, we can now extrapolate not only your chronological age, but your biological age. This is something that we do with PCR, DNA testing, and we can predict, besides your comorbidities, besides even sometimes the way you look, right? Like some people come in and they are 70 and they really look way younger. Then you have a 65 that look really, really older than the 65. And then we have been able to establish a little bit something more objective that is called the telomere. This study of these are pilot studies, right? Because these are new concepts, and people are actually went recently a couple months ago to a spine conference, and people are using and citing these things to patients about introducing to them the concept of biological resilience and biological age, because that helps you. Like they mentioned before, Baptists and the best healthcare in the world, they focus on the patient, and they wanted to make sure that expectations are aligned with the patient and as well as with the outcomes. And those are things that help us predict complication and determine how aggressive we can do with a deformity correction, with a surgery. Can you undergo a 7-8 hour surgery versus we have to try something less invasive and aggressive. So with that first pilot study, then it came in now we're talking about the concept of biological resilience, and this study implemented in artificial intelligence, now with predicted models, the importance of the biological dimensions using that telomere length. And they were able to predict patients with shorter telomere that they would not do as well. They wouldn't have the resilience. And when it comes to resilience, it's not only survive the surgery, is how long it's going to take you to recover from the surgery. One of the main questions that we get every day, any one of us that are treating patients every day, doing surgery, what is the recovery? What is the recovery? How long is it going to take me to recover from this, even if everything goes perfect? And we see that every day, right? We see a 10, 15-year-old break a leg, and they are fused and heal in 3 weeks, right? And then you have a 75 that break a wrist, and it might never heal, or it takes forever. So that is the concept of biological resilience, and that changes beyond the chronological age. There are patients that could be a chronological age of 70, and their resilience could be of a person that is 10 years younger. So that's something that we are trying to do the analytics with artificial intelligence. This study is from UCSF. The data is very new, and these are all pilot study of like 43, 50. I don't think they have one more than 100 patients. Because remember, they have to enroll to this, they have to do PCR, they have to do all the genetics before and after, and do the outcome measures. We are limited still by the measurements, by the outcome that we can measure as well. Because most of them, they still have to be validated, and they have a source of error. So going back to what we're doing here at Baptist, so we're taking this patient had a total of 11 surgeries before. I'm not kidding. And that's what he resulted on the left, and we did a more definitive correction that you can see it on the right. That surgery took about probably 7-8 hours, and you have to do pedicle subtraction osteotomy. So how you decide that this patient is a candidate for a more aggressive correction than the other we've been relying on all those risk assessment tools, but it would be ideal that now we can apply some genetics to be more truthful to our patients in terms of expectation, recovery, and ultimately outcome. These are other examples, and so in conclusion, the use of physical exam is still key. We're still doctors. It's surprising how patients come to us, any of my colleagues here, my team, and the feedback is like, oh my God, I've never been examined this well. You know, I'm a spine surgeon and I do cranial nerves. You know, I'm checking for hearing, and we have to do that because the patient is not just one organ, you know, right? It's all interconnected. We have to look at the red flags. There are things that on examination we encounter and that are very, very significant. It could be a tumor, it could be an infection, not just a pinched nerve. Manage symptoms for pain, and more importantly, educate and understand the complex medical decision process that can predict outcome and prevent complications in what we do every day. Thank you very much.
Thank you, Dr. Vasquez. Great presentation. Next up is, I'm very proud to introduce Dr. Guilherme Dabus. Dr. Dabus is our co-director of interventional neuroradiology and director of Baptist Health Miami Neuroscience Institute Fellowship Training Program in Neurointerventional Radiology. He's a clinical professor at FIU, Herbert Wertheim College of Medicine. And before joining us, he also served as assistant professor of radiology and neurological surgery at the Feinberg School of Medicine in Northwestern University in Chicago, and the director of the neuroendocrine program there, and neuroendocrine vascular program, and also neuroangiography there. He's a native of Brazil. I understand he plays a mean guitar, but we haven't been able to pin him down for that yet. I'm looking forward to jamming with him. He has many, many accolades, actually. He did his residency in Brazil at the University of Campinas. Am I pronouncing that correctly? Campinas. He did 2 fellowships, a neuroradiology fellowship at Northwestern University in Chicago, and then a interventional neuroradiology, neurointerventional surgery fellowship at McEnroe Institute at part of University of Washington, WashU in St. Louis. At Mass General, he did another fellowship, part of Harvard in Boston. So he comes with exceptional skills. He has well over 100 publications. He's been editors and guest editors for different journals in vascular and interventional radiology, acute ischemic stroke edition, etc. The American Journal of Neuroradiology, Special Collection, Vascular Lesions of the Head and Neck, among many others. He's an expert in the treatment of brain aneurysms, stroke, and vascular malformations. And he's an active lecturer both nationally and internationally. You're really going to be pleased by what you're hearing from him today, talking about transforming carotid artery stenosis treatment and the future of angioplasty and stenting. So it's with great pleasure that I introduce Dr. Dabus.
Ron, thank you very much. I promise I'll simplify my CV next time. Very good. So first of all, it's a great pleasure to be here and be able to give this presentation to you. It's great to see old friends, people that I haven't seen in a while. So I think, we're going to go for basically a ride on what is going on in terms of like carotid treatment, particularly on the arena of carotid angioplasty and stenting. These are my disclosures, nothing that is very relevant to this presentation. First of all, I'd like to say that, carotid disease treatment is truly a team effort. So we count with great vascular surgeons, cardiologists, neurosurgeons, neurologists, really coming to IR partners that really come together to really provide what's the best and really state-of-the-art for treatment for this patient. So keep that in mind. I'm very pleased with the team that we have. Again, I cannot thank them enough to really put together this amazing group to treat these patients, because those patients can be quite complex. The decision-making sometimes is quite complex, although it has been simplified more recently, but still there's a lot of debate on what's the best technique for each patient. So basically the idea of carotid disease treatment is very simple. You have this nasty carotid plaque. You can see here an example of like a pathological example. You have a ruptured plaque with lipid core exposed. Of course, it creates like inside loop thrombosis. It creates like distal embolization. So really what you're trying to prevent with any kind of treatment, medical treatment, carotid endarterectomy, carotid angioplasty and stenting, TCAR, is really to prevent the end result with the disease, which a lot of times is a stroke that could be quite devastating. It's important to understand how did we get here, and some of the seminal work that really like prove carotid treatment to be really the right way to manage these patients compared to medical management. And the first study is really the NASCET study. And the NASCET study was critical. This is a study from the 90s comparing medical management of carotid disease to carotid endarterectomy. Of course, in the 90s, the medical management for carotid disease was pretty much nothing more than an aspirin, very different the concept that we have nowadays. But the study clearly showed a big benefit in terms of preventing from future stroke from the patients that were treated with carotid endarterectomy compared to medical management. And this is basically on the patients that were symptomatic with stenosis from 70 to 99%. Now, NASCET-2 also showed that even if you have a lower degree of stenosis, 50 to 69, you still benefit of treatment or endarterectomy for treatment of carotid disease, although this benefit is much smaller than compared to the highest degree of stenosis. So I think that's important because we're going to re-explore this in the future later on this presentation. Now, when the investigators also looked into like timing for treatment and basically different in outcomes by gender, they actually showed some very interesting numbers. One is that the timing of surgery for the symptomatic carotid stenosis wasn't really influenced by the gender. So in terms of patients, symptomatic patients, there were males, there was no really different when did you operate those patients, as long as those patients were operated in a long time frame. But when they looked into the woman, for some reason that we cannot explain, actually the woman benefited from having the surgery early on in the first 2 weeks compared to like later on, as you can actually see here. And actually that's true for both symptomatic and asymptomatic. And although it's even early on for the asymptomatic patients, again, not really clear to how to explain this, but it's something that actually the NASCET data set actually demonstrated as well. Now, regarding carotid angioplasty and stenting, this is probably one of the procedures that has been the highest study probably in the whole history of medicine. I mean, we've been doing registries and trials since the early 2000s. And what we can see here very clearly, and something that we learned, and it's not only for carotid angioplasty and stenting, but actually for all types of procedures, is that patient or operator experience, patient selection, and the technology had really evolved throughout all the years to really make the procedure as safe as possible. So you can actually see here in this graph here the decline in terms of complication rate and positive outcomes that we see on those patients with more experienced operators, with better patient selection, and better devices to treat those patients. So that's something that, again, it's really something that we're evolved tremendously. And again, we have now data from thousands and thousands, over 5,000 patients entering registries, independently core-adjudicated labs, independently adjudicated results, showing that the procedure is actually very safe and as effective as endarterectomy nowadays. Now, there was still a lot of question, and one of the main questions that still is around, although there's less question, I guess, nowadays, because there's more data, and more data actually helps to make those decisions. But the question was, which procedure is better for the carotid angioplasty, for a carotid stenosis? Endarterectomy versus stent. And this was evaluated in the CREST study, which compared symptomatic patients that were allocated to either randomized to either endarterectomy versus carotid angioplasty and stenting. And basically what the study showed is that in terms of the overall composite outcome of death, MI, and stroke, there was no statistically significant difference between the two groups. So both groups were very equivalent. Now, when you look very specific, there was a slightly higher chance of minor stroke in the carotid angioplasty and stenting arm, and a slightly higher chance of MI in the endarterectomy arm. So this turned out to become a different debate now. What is better for the patient, have a minor stroke or an MI? So that actually is taken into account. So one of the factors that consider patient high risk for endarterectomy is coronary artery disease. But this was also looked into in the CREST subset. And actually what the investigators demonstrated is that it's worse for you to have an MI than having a minor stroke. Most of the patients recover from a minor stroke with really no significant deficits and no consequence to their life, but an MI during endarterectomy is associated with mortality in the long term for those patients. So this kind of answer a little bit that question that probably it's better to have a minor stroke in a procedure than really an MI during the procedure. Now, the other thing that CREST demonstrated is that, interesting, different than some of the concepts that we have, because for many years, the older patients were being sent to carotid angioplasty and stenting instead of carotid endarterectomy because they're considered high risk. But actually what the CREST data set showed is actually the opposite. It's safer for an older patient to undergo endarterectomy and a younger patient to undergo carotid angioplasty and stenting. And for us that perform these procedures almost like daily, we understand that because the older patients have more difficult arch, they have more calcified vessels, their anatomy is more difficult. So of course, if you're doing something endovascular, the risk of a problem there is higher than if you're treating a 50, 45-year-old gentleman with pretty straight vessels and just a carotid plaque. Now, when it comes to asymptomatic patients, that's another discussion that has been going on, and that actually it's the real question that we still have. Nowadays, there's no question that a symptomatic carotid stenosis should be treated, but there's still question if an asymptomatic carotid stenosis should be treated. And this has been addressed by many studies. The ACST, the ACAS study actually demonstrated that patients, when they were allocated to medical management versus endarterectomy, again, this is an endarterectomy study, did show a slightly higher benefit of the patients that were treated with endarterectomy compared to medical management. Now, again, those studies are quite old, and the medical management at that time are different than what we do nowadays. So there's some people that still didn't really believe that, and that actually what led to a larger study, which is still undergoing, which is the CREST-2 study. But when you go down and look into some other studies that were done, this is the ACST2, which compared for asymptomatic patients, carotid endarterectomy versus carotid angioplasty and stenting, did show similar to CREST, so similar to symptomatic patients, asymptomatic patients, there's really no difference in the composite outcome between carotid endarterectomy and carotid angioplasty and stenting, as you can actually see here. Now, similar again, there is a slightly higher number of minor strokes on the carotid angioplasty and stenting arm compared to the endarterectomy arm, although, as you can see here in this graph, none of them really reach statistical significance. So there's no statistical significance between results, but there is a slightly higher, more incidence of minor stroke in the angioplasty and stenting arm, as you can actually see here. However, when you exclude any kind of procedural death or any fatal or disabling stroke, or any non-procedural fatal or disabling stroke, there's really no difference. The graphs are exactly the same. So if you exclude minor stroke, the results between endarterectomy and angioplasty and stenting are pretty much exactly the same. So again, demonstrating a very safe and effective procedures both ways. Now, when we talk about asymptomatic carotid stenosis, again, there's a lot of discussion that comes in and still tell us, okay, do we believe in the ACST and the ACAS trial, older trials, older medical management, but what is the really current evidence when you're really now treating patients with antiplatelet agents, high dose statin, really blood pressure control, glucose control, telling patients to stop smoking, exercising. And this is a very interesting study. This is usually what I quote for my patients with asymptomatic carotid disease because that's the best data that we have more recently. And this is like a study called the OXVASC study. Basically, they look into patients with asymptomatic carotid stenosis and they stratify them according to their stenosis. And basically what the study showed is that if you have an asymptomatic carotid stenosis that is less than 70%, the risk of you having a stroke is very close to zero. Nothing is zero in medicine, but this showed is very close to zero. However, if your stenosis starts to get higher than 70%, particularly higher than 80%, you may have a yearly rate of stroke that can reach somewhere close to 3 to 5 to 4%. So that's not an insignificant risk. 3% risk of stroke accumulating like 15, 20% in 5 years is a pretty significant risk compared to a procedure that will pose you like 2 to 3% risk of having a minor stroke mostly So again, I do tell this to the patients. I don't know what's the best answer because actually the real study that will tell you if you should or not treat asymptomatic patients that's going to show us the best clue for that is really the CREST-2, which is just finished enrollment. So I feel that probably in the next few years, we're going to have results. I'm part of the interventional management committee for it. So we look forward to the results. And the CREST-2, basically the patients are randomized to medical management versus either carotid angioplasty and stenting or endarterectomy. So it's really comparing medical management to any form of treatment, which is, depending on the center, would choose which treatment to do. So when we have the result, then we're going to be able to tell for sure that asymptomatic patients should or should not be treated either with endarterectomy or carotid angioplasty and stenting. So again, as I mentioned, carotid angioplasty and stenting, very straightforward procedure, okay, for us. We can treat very nasty plaques like this picture on your left side there. The procedure is most of the time straightforward and the patient has selected the correct patients with good anatomy, patients that are straightforward. We usually use these little filters. It looks like a basket. So when you're doing angioplasty and put in stent, if something breaks off, you get caught on those nets. And then the risk of having a problem is much smaller because that actually can filter pretty significant sized particles. Tiny ones will probably go through, but the bigger ones are caught. So that's probably why when you have something, it's usually a minor stroke. So again, over 5,000 patient studies. It's very comfortable for the patient. It's a procedure that takes usually about 45 minutes to be skin to skin, as you call, like from the start, from the puncture to the closure of the groin. And can be done femoral, can be done radial nowadays. I still prefer to do most of my cases femoral, although radial is a good approach, and I've done several cases like that. I think the patients a lot of times like the radial approach more because they don't need to be laying down flat, but still it can be a little bit challenging sometimes. Now I'm going to show just some quick cases. This is a patient, a 47-year-old, who get presented with symptomatic carotid stenosis, has a tiny stroke on the left hemisphere, and this patient actually then comes back in, had a carotid ultrasound actually that you can actually see here. That's how a lot of times we look. This is the first screening tool for carotid stenosis, is carotid ultrasound. And you can actually see here a very, very high velocity, peak systolic velocity of 570 centimeters per second, and diastolic velocity of greater than 280 centimeters per second. That really tells you that this patient has a very severe stenosis, greater than 80%. And then, of course, symptomatic greater than 80%, this patient should be treated. Unfortunately, in the meantime, this patient actually occluded that carotid and presented here to Baptist with, as an acute stroke, what we call like a tendon occlusion with distal embolization. So I was able to go there, do a thrombectomy, angioplasty of the neck, and then do a thrombectomy intracranial. The patient actually had a very good recovery. So we brought this patient back 1 week later to just finish the job, and you can actually see here the residual carotid stenosis there. And then, very straight vessels. This is a perfect case for carotid angioplasty and stenting. You just pass your filter. You can actually see the filter. I don't know if this is a pointer here, but okay. Either way. So you have the filter placed distally in distal cervical carotid artery, and then basically you just do the angioplasty, put the stent, and you can actually see here the final result. Really recanalization of the vessel. We always measure the diameter of the vessel based on the NASCET criteria, which means you measure not at the bulb, but you measure the area where you put the stent to the distal cervical area, straight segment. And really, with this, you really usually have no, in this case, what we call no significant residual stenosis. And this is basically the carotid ultrasound. The next day, you can see here the velocities start to normalize, and 4 months later, the velocities couldn't be like better than this, 60 over 21 in the peak systolic and diastolic velocities. This is another case, and again, the other technique that we use a lot, carotid ultrasound we always do, but we also do a lot of CTA. CTA is very interesting. I mean, you can see big details of the plaque there. You see the calcification, you see the soft component of the plaque, you see this very irregular, nasty plaque with a big ulceration and reentries. And you can understand, why this patient becomes symptomatic. You can form clot there, but there's also like in situ thrombosis that happen because most of those plaques are ruptured, and you expose the lipid core, and basically becomes like an in situ nidus for thrombosis. And as you see here in the angiogram, we can do 3D angiograms. You see the big plaque ulceration. You go there, and again, you do the angioplasty and stenting. This is a cone beam CT demonstrating the stent. Some of these plaques, they're very calcified. They're never expand totally. And you don't want that to happen because that increases the risk of distal embolization on a cheese grating kind of effect type of deal. So you don't need to have like the full perfect result. You just need to open the vessel enough that it matches somewhat the distal caliber of the carotid artery. Now, the other option that we have that is very similar to carotid angioplasty and stenting is an angioplasty and stenting, but is instead of doing through a femoral approach or to a direct percutaneous approach, it's done through a carotid exposure. It's called TCAR, transcarotid artery revascularization. We used to do we do a lot of these cases sometimes in conjunction with our vascular surgeons. And you know, it's a very, very good procedure. It's a procedure that gained a lot of momentum in the last few years, particularly because of reimbursement issues with carotid angioplasty and stenting, which kind of had been resolved by now. But it's a very, very good procedure as well. And the idea of TCAR is that if you have patients like this with very bad aortic arches, very tortuous common carotid arteries, or very tortuous internal carotid arteries, this may be a better option because you have a direct cut down, you get access to the common carotid artery, so you bypass all the arch and all the calcification, all the risks that you have through going through that. So the idea of TCAR is basically do a carotid cut down, you put a big catheter directly into the carotid, which is exposure, it's ligated by the vascular surgeon, and you create a shunt. Because you ligate the carotid proximally, then what you do is basically connect the catheter that is in the carotid and the common carotid artery to the femoral vein line that you have, which is through a big sheath, and that immediately reverses the flow because the carotid system is a high resistance system compared to the venous side, so the flow directly gets reversed. And actually, it's a very, very robust way to protect carotid from distal embolism because the flow gets reversed immediately. And after the catheter is deployed, like we can actually see here, you know, the shunt is performed, the carotid is ligated. Then it's very easy because you don't need to use a filter because you have a flow reversal for protection. You do the angioplasty, you put the stent. You see here and then there's a filter that connects the carotid to the venous, to the femoral vein. And you can actually open the filter in the end and you see all the debris that got caught on that filter. So, you know, this is something that potentially would all go to the brain and embolize. And we had some cases that we had done MRIs after these procedures, and actually they're pre-clean, which a lot of times you may see little things, but in this case it's actually just proving that it's a very robust way to protect the brains with the slow reversal. So I think the key things here, to take home and to really understand, is that we have great ways to treat carotid disease, okay? Even the medical management has progressed a lot, and now with like statin, high-dose statin, antiplatelets, blood pressure control, diabetes control, you know, smoking cessation, those are very powerful way to control the disease. However, if you do have a symptomatic carotid, that needs to be treated. There's no question about that. The question still remains for asymptomatic, although there's, you know, not through a randomized trial, there's evidence that if you have greater degree of stenosis in asymptomatic patients, these patients probably still should be treated. So in the end, really, carotid angioplasty and stenting, TCAR, are very effective and safe carotid disease treatment, similar to what is in the arterectomy. So we have 3 great options. The main thing here is to really use your multidisciplinary team approach to decide what's the best way to treat that patient and really provide those patients the best chance of a good outcome. Thank you very much for your attention. I'm happy to entertain any questions.
I really look so short compared to him, don't I? Actually, I'm the shortest guy at the table. Well, maybe Dr. Vasquez and I could fight it out. That was an outstanding lecture. Thank you so much, Dr. Dabus. Our next speaker, Dr. Vitaly Siomin, I've known for 12 years that I've been here at Baptist, and he actually preceded me as one of the first neurosurgeons to join the Baptist Health Medical Group. When I first came here, he was my go-to neurosurgeon for spine and everything. And as we grew in the Miami Neuroscience Institute up to over 42 doctors now, we've expanded, and you're seeing a lot of our specialists are subspecialized. And Dr. Siomin does more of the cerebral vascular and brain tumor surgery. So he is the director of cerebral vascular and epilepsy surgery and the co-director of our skull-based surgery program at Baptist Health. He has broad experience in open cerebral vascular, skull-based surgery, brain tumor surgery, and other types of cranial surgeries, and performs complex spine procedures, spinal instrumentation, suboccipital decompressions for Chiari type 1 malformations, and he's certified by the American Board of Neurological Surgery, as are all of our neurosurgeons. What I did not know as well is, well, first, I don't know whether he plays an instrument. He is one of the most humble people that I've met, and one of the most brilliant physicians I've ever met. And but I didn't realize he actually did 4 fellowships. He graduated from IM Sekhanov, first Moscow Medical Academy in Russia, then completed, follow me on this, okay? He completed residencies at Burdenko Neurosurgical Institute in Moscow, and then again a neurosurgical residency at Cleveland Clinic Foundation in Ohio. Then he completed a fellowship in pediatric neurosurgery at Tel Aviv Sourasky Medical Center in Israel, followed by a neurosurgery neuro-oncology fellowship at Toronto Western Hospital, University of Toronto in Canada, and then a brain tumor fellowship at the Cleveland Clinic Foundation. So 4 fellowships. He's participated in clinical and basic research on brain cancer. He's published in several medical journals, including the Journal of Neurosurgery, Neuro-Oncology, Neuroplasia, Pediatric Neurosurgery. He's done almost everything. And as I said, he's just an all-around great person, humble human being, but a brilliant man. So it's my pleasure to introduce Dr. Sioman.
Thank you, Ron. I appreciate this kind introduction and the multiple fellowships. This is a path of a foreign medical graduate to an American medical system. So probably many of you know that. But in any case, how do we? All right, so we'll talk today about treatment, microsurgical treatment of brain aneurysms. So aneurysms are common. 1 to 6% of the population would be diagnosed with an aneurysm, either incidentally or after a clinical presentation. And there's only minimal evidence to suggest that the aneurysms are inherited, and most likely etiology is typically hemodynamic injury, stress to the walls, especially in the areas of the bifurcation. But they might be associated with different conditions such as connective tissue disorders, Marfan, Ehlers-Danlos, FMD, polycystic kidney disease, and coarctation of the aorta. There might be multiple in up to a third of the patients, especially if other vasculopathies are present. 75% of the patients would have 2 aneurysms. They become symptomatic in patients who are 40 to 60-year-olds. The majority of the aneurysms occur in the anterior circulation. 30% of them are in ACOM, PCOM, followed by MCA, and pericallosal artery would be probably the least common. Most typical clinical presentation with subarachnoid hemorrhage. And obviously it's the worst headache of a patient's life. We use Hon-Hess scale to measure the clinical severity. We utilize the Fisher gradient scale to correlate the amount of blood and correlate that with occurrence of vasospasm and outcome. About 20 to 30% of the patients never even make it to the hospital. They just die in the scene. And out of those who make it to the hospital, about 50-70% remain very disabled and in need for prolonged assistance and even major assistance for the rest of their days. The natural history it depends on the size of the aneurysm. It's sort of like it's been moving target. Initially, we thought that aneurysms that are larger than 10 millimeters would be dangerous and you have to treat them. Then it turned out that those that are larger than 7 millimeters, and now, in fact, the majority of the aneurysms, there's a growing body of evidence to suggest the majority of the aneurysms that actually rupture are about 5 to 6 millimeters in diameter. So whenever you see an aneurysm of that magnitude, something probably needs to be done. There are risk factors, and typically they involve cigarette smoking, cocaine abuse, use of different substances, which could lead to vasculitis and intimal injury. Female sex is another risk factor. Family history of aneurysm, presence of different conditions that might be associated with aneurysms, such as polycystic kidney disease, SLE. Hypertension is a risk factor, and aneurysm shape. When there's Murphy's excrescencies and irregular dome, that would be one of the risk factors for rupture. What are the treatment options for unruptured aneurysms? We can follow them if they're small and the patients don't have risk factors, or we can proceed to treatment if they are larger in size and there are risk factors. Treatment may involve clipping, and I'm a surgeon, that's something that I do. bypass with clipping, wrapping of the aneurysm, some historical treatment options such as Hunterian ligation. Coiling is a type of treatment that endovascular colleagues provide. Stent-assisted coiling and flow diversion is another more recent option. Treatment options for ruptured aneurysm are essentially the same, but we obviously cannot follow them. We utilize different medical aspects of aneurysm care, so we admit those patients to the ICU. We have, I believe, 4 and probably even more now fellowship-trained neurointensivists at Baptist, and we communicate with them, and just they're very good quality people. Patients are typically lined up. We need to control their blood pressure. Nimodipine is given for 21 days. To prevent vasospasm. Seizure prophylaxis is an important part of this. So we don't prophylax for, for the whole duration, but usually 5-7 days is typically sufficient to minimize the risk of seizures. Vasospasm incidence is highest between starting on day 3. Initially, the patients have honeymoon, no vasospasm, but day 3 to up to 3 weeks, the incidence of vasospasm is highest. And that's when it's important to do serial TCDs and sometimes provide even medical treatments such as hypertension, hypervolemia, calcium channel blockers. And another aspect of medical treatment is the patient have mycotic aneurysm. We treat them with antibiotics. It's important to continue antibiotics to secure the aneurysm. The goal of treatment would be to achieve complete obliteration, whether you do endovascular, when you treat the aneurysm endovascularly or you treat it surgically. The multidisciplinary approach is very important, and when we get together, typically angiography is done, patient is evaluated clinically, and then we decide which aneurysm would be treated best with coiling or surgery. And neurosurgeon is typically involved, interventionalist, intensivist, plus minus neurology, rehab specialist. Very recently we got what's called the mobility teams. So patients postoperatively need to be mobilized, and it's very difficult. Sometimes on the weekend, patients, nobody would come and see and mobilize them. And we created those mobility teams when you just trigger the consult, and patients would be evaluated and pulled out of bed, and therapists would evaluate them. And it's done in conjunction with, between the various, in cooperation with various clinical specialists. Coiling provides better disability outcomes in 1 year based on the results of the ISAT trial. Clipping, if the aneurysm is uncoilable, then we should perform clipping of the aneurysm within 48 to 72 hours before the vasospasm starts developing. And if stenting is performed based on the ISAT trial, it might be riskier than either of the options. Coiling is a kind of very straightforward procedure, lower cost, less invasive. The disability and morbidity is lower at least in the short run, based on the ISAT trial. The risk of vasospasm is also somewhat lower. The interventional radiologist can also administer intra-arterial vasodilators to treat vasospasm. It's better for posterior fossa aneurysm, probably because of the technical challenges associated with open clipping. Better tolerated by elderly patients and patients in poor neurological grade. And the risk of seizures and cognitive and adverse cognitive events is lower with coiling. So that's what we're competing with as surgeons. Like when you talk about surgery, then you get somebody, head is clamped in a vise, you shave the hair. We actually use the zigzag kind of incision so that if you have a straight incision, the hair parts, you can see it. If you make it like this, so you can't see. But I mean, we try to do different tricks, but it's a big and invasive procedure. You open up the brain, split the fissures, go in there, suck out the clot, manipulate between the cranial vessels. Like this is a case of a clipping of a PCOM aneurysm. You see the brainstem down below, cerebellum pushed up, cranial nerves going to the IAC. It's a big procedure. When patients are presented with these options, obviously it's endovascular colleagues win. But there are cases that we have to do that, and it's unavoidable. Clipping requires an experienced neurosurgeon. It's typically just one procedure. You don't go back and forth and let's just throw some more coils. let's just put the stent now, let's just do this. It's just once you're done, there's a 98% chance you're not going to bring this patient back for any other procedures. Extremely low recurrence rate, as we mentioned. Probably more versatile with various aneurysm shapes, especially if you have an ectasia in some branches coming off of the aneurysm. Then it's obviously clipping. You can just directly visualize and put your clips in such a way that would prevent the occlusion of the vessels. You can evacuate the blood, and it's although controversial, but you may potentially decrease the incidence of vasospasm. Based on the ISET trial, there's no evidence of increased mortality at 5 years, like in the long run. Clipping involves various adjuncts. We utilize CSF drainage, early identification of the basal cisterns, draining the CSF. We ask anesthesia to provide induced hypotension in the most critical parts of the procedure. We utilize mannitol to relax the brain, hyperventilation, minimal brain retraction, preserve the veins. As you see, this is a Sylvian-Fisher split, and the clips are placed on the MCA bifurcation aneurysm. The dissection has to be performed in a very gentle way. Basically, I don't use retraction system, except for dynamic retraction with the tips of the instruments over the cottonoid patties and rubber glove sliders. Only the most critical part, when you have everything exposed, we put the retractors to maintain the field, but not really so much to retract per se. Circulatory arrest used very sparingly, but once it saved me and the patient, because the bleeding was from the ruptured aneurysm was extremely uncontrolled, and the anesthesia had to give adenosine to get the circulatory arrest for a few seconds when we were able to put the clips to control the bleeding. The risk of recurrence with clipped aneurysm is very low, and like in this series, the de novo aneurysm formation was detected in up to 8% of the patients. That's why it's important to follow up. Even if you think that clipping is good, secured, put the clips, everything is good, there's no dog ears, no recurrence, it's still important to ensure long-term follow-up and do another angiogram, maybe about 5 years, 9 years, 10 years, something like this, because there's still about a small percentage of patients that would require treatment for either recurrent aneurysm or de novo aneurysm. Well, we will not go over the details. I just wanted to pick up this study because it's large, it's randomized, and it was done at a major, very credible institution, Barrow Neurological Institute. So they analyzed 725 patients. They compared coiling and clipping, and it's important. They made the conclusions immediately after the study, and then they did the 6-year results, and it showed that statistically, they came up with a criticism that the study was underpowered to detect small differences because the differences between the technique were relatively small. 6-year results suggested little difference in outcome between coil and clipping for the anterior circulation aneurysm, but for posterior circulation aneurysm, the difference was very significant, and coiling has very clear advantage. Obliteration rates in Brett's study were significantly lower, and retreatment rates significantly higher in the endovascular treatment patients. And despite higher retreatment rates after coiling, there's no recurrent hemorrhages in the endovascular group, as long as for this whole duration of follow-up for 6 years. So the difference probably is going to be very minimal, but we still should have both options available and select them sparingly for different patients depending on the criteria that we mentioned before. So which aneurysm should be clipped? Young patients, it would be probably the preferred method of treatment because it provides the low recurrence rate in the foreseeable future and even the long-term future, in the extended long lifespan. They may have recurrence, and it's important to secure them once and for all. In older patients with significant vessel kinkiness, although the endovascular procedure is typically better tolerated by elderly patients, but sometimes you just can't navigate there. If you have very advanced atherosclerosis, it might be hard for the endovascular operator to advance the catheters there and manipulate. So some of these patients end up being clipped. Ruptured aneurysm with ICH, mass effect, when you really need to decompress the brain in addition to secure the aneurysm. The aneurysms with wide necks, especially MCA bifurcation aneurysm, which are very difficult sometimes. The blood vessels take off, and you need to remodel the entire bifurcation with clips, which is much easier to do it with clips. Distal aneurysms, which are typically small, and aneurysms smaller than 2-3 millimeters are difficult to coil endovascularly. As we mentioned, when distal branches originate from the aneurysm, and after endovascular treatment failure, when you have a lot of coils in the aneurysm that keeps recurring, especially giant, large aneurysms, and ruptured previously coiled aneurysms. So these are the typical candidates for clipping. We utilize temporary clipping for about 15 minutes, careful monitoring, burst suppression, induced hypertension. Be careful with neck calcifications, aneurysm thrombosis, atherosclerotic plaque are all little mines that you have to navigate around. Sometimes you have to spare the STA for bypass, consider neck exposure, have the neck ready for aneurysm, especially some periophthalmic aneurysms when it would be difficult to control intraoperatively. And intra-op angio is utilized very essentially in almost all cases. Sometimes temporary clipping can be very long. So like this case we just did recently with Dr. Wicks, it was just a giant previously coiled MCA bifurcation aneurysm. So we had to open up, expose the entire aneurysm, open it up, excise it, remove all the coil mass. And obviously, it's a very lengthy, tedious process. So the temporary clips were in place for 40 minutes. Like really nothing happened somehow. It's just sometimes be better lucky than good in these cases. Clipping strategy involves clipping of the aneurysm and evacuation of the hematoma. You have to utilize 3D thinking. It's very important. So I'll give you a couple of examples. Especially in MCA bifurcation aneurysms. So sometimes the aneurysms are very irregularly shaped. Sometimes the branches can be continuation of the body of the aneurysm. The whole bifurcation is diseased. And you have to utilize different angulation clips, fenestrated clips to recreate the bifurcation and preserve the natural, the normal vessels. Sometimes we use cotton because sometimes you can't really provide that perfect clip application. And there's still some thinning out of the blood vessel wall, even the normal part of the normal vessel. So sometimes we apply the cotton to induce scarring and maybe enhance the wall of the normal vasculature to prevent the recurrence. This is a case when we utilize the IC green angiography. So this is how you have to dance around the normal vessels and atherosclerotic plaques and calcifications in a patient with fusiform MCA bifurcation with atherosclerosis. Ophthalmic artery aneurysm is also sometimes we clip them, and you don't have to mobilize the optic nerve to be able to see the aneurysm and approach the neck. It requires the clinoidectomy. This is it's one of the typical cases. Then once the clip is placed, sometimes you can't really maneuver the clip in such a way that would be that the clip mechanism would be away from the optic nerve. And what can happen is that it can push, like you see on that left illustration, that it's sort of like right up against, immediately adjacent to the optic nerve, and sometimes it can cause optic neuropathy. Sometimes you have to utilize microsurgical skills to suture the clip away to the dural remnant and move it away from the optic nerve to achieve that gap and prevent the optic neuropathy. We actually published on that. So this is a case of a ruptured ACOM aneurysm. And these aneurysms are challenging because you need to, the vision is obscured. You have to resect a little bit of a gyrus rectus to get a good visualization. Attention to the parent vessels is critical, and the perforators. There's a bunch of perforators there. Depending on the angulation of the aneurysm, you have to be very careful with them and clearly visualize them. This is a case of a giant MCA bifurcation aneurysm, 67-year-old patient. They tried to put the stand. It was unsuccessful. And we have to move away from flow diverter to now direct clipping. The high flow bypass had to be done because it's a very large caliber vessel that would have to be done. And I just quoted here from Dr. Shaker, who's a very known authority in this area. So he calls it temporary. He calls it the creation of the bypass is a higher level of technical skill is needed, and is an operation with 1,000 steps, all of which have to be executed properly. So this patient underwent craniotomy. And at the same time, the vascular surgery team worked on harvesting the radial artery graft. You can see the steps of the arteriotomy in the external carotid artery. Then we sew in the radial artery graft. Then the graft is tunneled to the cranial exposure, and the bypass is created. After that, you have to somehow anastomose the two branches because they were before you actually clip the aneurysm, so that there would be a blood flow established between the superior and inferior division. So then we create an in situ bypass between the superior and inferior division, check the patency with IC green angiography, and then the patient is brought back to the endovascular suite where the endovascular team would perform the coiling. So it's sort of like multi-step complex procedure. It's not done every day. These are just nerve-wracking kind of challenging cases. We started utilizing the exoscope. It gives you a 3D perception. Everybody in the operating room wears goggles, and we can see things in 3D. And it's, the key is just to bring it closer to you so that you can just completely immersed into surgery. It's actually very cool. I absolutely enjoy these cases myself, and I like that everybody else in the operating room, techs, medical students, everybody is kind of like watching it in 3D when you have a vessel which is normally at 2-3 millimeters that is just magnified to a size of a huge pipe, and then you can just see the microanatomy in all of its beauty. That's a case of clipping of the aneurysm using an endoscope. I'll just skip on. So intraoperative angiography is important, and the conclusion of one of the series is that up to 20+% of the patients may need to be brought back to the operating room after intraoperative angiography to reposition the clips, because the parent vessels can be clipped, and for that optimal clipping. Catheter angiography is probably very similar in the extent of visualization and as far as the outcomes are concerned to the IC green angiography, but we're still kind of hesitant. We usually utilize both. The complications of clipping, not very high, but they're not zero either. So the morbidity is 2.3%, is size dependent for aneurysms that are smaller than 5 millimeters, 7% for 6 to 15 millimeters, 14% for 16 to 25 millimeters. There's a 10% chance of intraoperative rupture. I can attest that's the same thing in my personal experience. There's a risk of stroke, venous infarct, seizure, and obviously craniotomy-related complications, infection, wound healing, bleeding, seizures, temporalis muscle atrophy, etc. In conclusion, surgical clipping is a very well-established treatment option. It should be preserved, even though the endovascular options are making advances, and there's a lot for them to progress, whereas the neurosurgeons sort of reach the plateau. This option should exist for selected patients. It will remain an option for patients in most institutions. Microsurgery should be strongly considered for younger patients with aneurysms in the anterior circulation, especially MCA bifurcation aneurysms, for giant aneurysms, for aneurysms with wide necks, in older patients with tortuous vessels, and when coiling failed and there's really no other options for these patients. Multidisciplinary approach is essential, and also in aneurysm surgery, you got to be prepared for everything, to utilize your skull-based skills, to utilize microsuturing techniques, and all other general neurosurgical techniques. So it's an interesting, the picture you can see, this is one of my patients after aneurysm clipping. So she had staples, we removed the staples, and she took them and used that to make this little necklace after surgery. Just put like this power, love, hope, and all of that stuff. So, I'm glad that we were able to help. And thank you all very much for your attention. It was a privilege. Nice to see you all here. Welcome to Miami. And thank you very much again.
So that was wonderful, thank you. I want to remind everybody that there will be a question and answer session following the end of our morning speakers, and our speakers will all be up front for that Q&A session. So please make sure as you come up with questions during this that you write them down and prepare them for later. To prepare to be a moderator today, I watched a roast. Some of you may know what I'm talking about, others may not, but I watched a roast of Dean Martin and a whole group of comedians on Frank Sinatra, a roast for Frank Sinatra. It was held in the early 70s, but I can't remember any of the jokes from it, so I'm not sharing any of them with you today. So I didn't do a good job on that preparation. All right, so our next speaker, Dr. Evan Bander, when you see him up here, you'll understand what I'm about to say. He looks like he's right out of high school. but he's really not. He is the director of endoscopic skull-based surgery and pituitary tumor program here at Baptist. He's our most recent neurosurgeon to join the Miami Neuroscience Institute. He's only been here just a couple of months, and so he treats both benign and malignant brain tumors. He earned his degree from Cornell University in New York, and then went on to do his residency at the New York Presbyterian Hospital in conjunction with Weill Cornell Medical College and Memorial Sloan Kettering Cancer Center in New York as well, and completed a neurosurgical residency and served as chief resident, and also went on to receive the Leon Levy Neuroscience Research Fellowship and Minimally Invasive Skull-Based Surgery Fellowship in New York. So he really comes with great training. He then went on to do a Neurosurgical Oncology Fellowship at MD Anderson, famous cancer institute in Houston, Texas. And he's extensively published already. So early in his career, he's had numerous awards and accomplishments, and I'm just looking forward to seeing what he does later in his career. So it's with great pleasure that I introduce Dr. Bander, who will be speaking to you today on the role of neurological oncology in managing brain mets.
Thank you. It's an honor to be here and to speak to all of you, so thank you to Baptist Health International for organizing this. As you heard, I'm one of the newer members of MNI, and I've only been here for 3 months, so I'm honored to be joining you today. So as you heard, I wanted to give a little bit of background on where I came from since I've only been here for 3 months. So I trained and grew up in New York City and trained at Memorial Sloan Kettering and Weill Cornell Medical College in New York, and then did a fellowship in neurosurgical oncology at MD Anderson, which is what I'll be focusing on today. And then I joined here at Baptist Health. So as a neurosurgical oncologist, brain metastases really make up a majority of our practice because these tumors present as is the most common brain tumor found in adults. Epidemiological studies have demonstrated that about 8 to 10% of patients with systemic cancer present or eventually are found to have brain metastases. The most common pathologies to occur in the brain are lung metastases, breast cancer, as well as melanoma, which is followed subsequently by renal and GI malignancies. Now, local therapy with surgery and/or radiation are really the mainstays of treatment for brain metastases. And really, it's the combination of multidisciplinary care between neurosurgeons, oncologists, and radiation oncologists that's vital to determine the best treatment for these patients, which is why a place like Baptist Health and Miami Cancer Institute with Miami Neuroscience Institute collaboration is so important. So, historically speaking, the prognosis of patients with brain metastases has been considered dismal and a very poor prognosis. But thankfully, however, that is changing, and the paradigms are shifting in brain metastases because we're seeing significant improvements since the age of molecular targeted treatments and immunotherapies have been introduced. We've seen a huge number of drugs developed over the past decade, which have really changed the landscape of brain metastasis treatment and treatment of systemic cancers in general. So these timelines just show that over the last decade, we've seen both in melanoma and non-small cell lung cancer. Since 2010, we've seen a huge number of drugs that have been introduced into the treatment paradigms for these systemic cancers. And what's important to note is that the introduction of these treatments have actually made a big difference in the prognosis of patients with brain metastases as well. So we evaluated over 200 patients treated with melanoma at Memorial Sloan Kettering while I was there, and what we found was that since 2015, compared to patients treated before in 2010 to 2014, we saw a doubling of the patient survival. Overall survival went up from 7 months after diagnosis to up to 13 months after diagnosis for patients with melanoma, just since the introduction of immunotherapies and targeted molecular therapies. We're also seeing in other publications similar improvements in survival in patients with breast metastases as well as lung metastases. So it's not just that the systemic treatments are improving systemic control of disease, but we're also seeing that these new molecular therapies and immunotherapies are actually having direct effects through the blood-brain barrier on the brain metastases themselves, where we're seeing patients treated with antibody-drug conjugates, such as in breast cancer through the DEBRA trial, showing objective response rates in the brain metastases themselves. So with all of these advancements in brain metastases and systemic therapies, we've seen survival improving, which really makes the importance of local control within the CNS and within the brain even more important. So I'm a neurosurgeon, I'm not an oncologist, so I've told you about all the advancements that oncologists have made, but where do neurosurgeons fall into this? So the role of a neurosurgeon was really cemented back in 1990 with randomized controlled trials led by Roy Patchell, which showed that surgical resection of solitary brain metastases when combined with radiation therapy led to improved local control, as well as improved overall survival and prolonged functional independence of patients treated with surgery plus radiation compared to radiation alone. In 1998, he also showed that surgery combined with radiation was of benefit rather than surgery alone, because local control was significantly improved when you combine surgery with radiation. So really this cemented the role of multidisciplinary care in treatment of brain metastases. So after the Patchell trial, traditional indications for surgical resection have usually focused on solitary or oligometastatic disease, primarily patients treated for local control of dominant large tumors. Usually a cutoff of 3 centimeters is quoted in the literature for large tumors, and then patients who have symptoms, who require palliation of symptoms, is another major indication for surgical resection prior to radiation. In addition to that, there are patients that may need histologic or pathologic diagnosis, so surgical resection can provide that, and they may also have been treated previously with radiation and may have a question of whether they have recurrence versus radiation necrosis and may require resection for that reason as well. Now, in general, hemorrhage is also a common presentation within brain metastases. It's not always an indication for surgery, but in some cases, especially in patients who require anticoagulation, surgical resection of hemorrhagic brain metastases can be indicated to allow them to get back onto anticoagulation in a more quick manner. So those are some of the traditional indications for surgery, but as we've seen improvements in medical therapy and as also we've seen improvements in radiation therapy with the introduction of stereotactic radiosurgery, we've seen that local control rates for stereotactic radiation alone are actually very excellent in small brain metastases. But a recent study that was published from MD Anderson evaluated the effect of stereotactic radiosurgery alone as an upfront treatment, and what they found was that the size of the tumor, as well as the primary histology, were very important in determining the control rates. And what they found was that even patients who had tumors that are less than 3 centimeters, there was still a steep fall off in the local control for patients who had tumors even above 1.5 centimeters. So surgical resection may actually be indicated in some of these patients depending on their histology and our ability to predict their local control with stereotactic radiosurgery alone. The role of surgery may be expanding beyond just patients with tumors greater than 3 centimeters. In addition to that, there's been some interesting evidence out of MGH with Dr. Brastianos' group, who evaluated the genetic mutations of brain metastases that had been resected and compared them to the primary metastases, or the primary tumors resected, and found that in brain metastases, there were actually 50% of patients that had systemic targetable molecular alterations found within the brain metastases that were not present in the primary tumor. So this could, as we develop even more targeted therapies, become relevant as we may need to get pathologic diagnosis from the brain metastasis as opposed to just relying on the pathology from the primary tumor itself. So now that I've talked about sort of some of the indications for surgery, are there things that we can do as a neurosurgeon to improve our local control? So a number of studies from MD Anderson have demonstrated that the actual technique used during surgery can affect the local control rates. So en-bloc resection, or taking out the tumor as one piece as opposed to taking it out in small pieces in a piecemeal manner, can actually improve local control after surgery. In addition to that, en-bloc resection has been shown, especially in eloquent areas of the brain, to decrease complication rates for en-bloc resection compared to piecemeal resection. and particularly in patients with posterior fossa metastases or in the cerebellum, en bloc resection can lower the rates of postoperative leptomeningeal metastases compared to a piecemeal resection. So how we resect these tumors really does matter. As I mentioned, stereotactic radiosurgery has really become the most common form of external beam radiation therapy we use for brain metastasis treatment. But what we found was that after surgery, the time from surgical resection to stereotactic radiosurgery can vary very widely in patients that were treated at Memorial Sloan Kettering. We found ranges from 14 days to up to 90 days. So we evaluated what is the role of timing of stereotactic radiosurgery for adjuvant treatment in brain metastasis, in resected brain metastasis. What we found was that while overall we were having excellent local control rates for surgically resected and adjuvantly radiated brain metastasis with recurrence rates of only about 14% all the way out to 5 years, we found that the timing of that stereotactic radiosurgery significantly correlated with the local control rates. A cutoff of about 34 days was statistically significant for recurrence rates in that population. And what we saw was if we treated patients after resection with stereotactic radiosurgery within 1 month, we were having local control rates with recurrence as low as 6% at a year. But if we treated patients up to 2 months after surgery with stereotactic radiosurgery, their recurrence rates were almost as high as 27%. So that was really significant in determining, these patients can't just be surgically resected and then assume that radiation is going to happen in a timely manner. It has to be organized in a multidisciplinary manner and done very meaningfully. So we took that actually a step further at MSK while I was there and evaluated a prospective cohort of patients who we delivered radiation within 14 days after surgery to evaluate whether we had better results with that. What we found was that within 14 days we did have excellent local control rates, but they weren't actually significantly better than patients delivered stereotactic radiosurgery between 15 and 22 days or 21 to 30 days. But we actually found that there were higher rates of adverse radiation treatment effects if we treated them within 14 days of surgery. So what we actually found was that the optimal timing for treatment after surgical resection with radiation is around 20 to 30 days after surgery. So again, this timing and coordination of care is really important in the treatment of these brain metastasis patients. Now, in addition to stereotactic radiosurgery as a form of adjuvant treatment, brachytherapy is actually becoming a very popular field within the neurosurgical oncology community. Now, brachytherapy is actually delivery of the radiation source into the tumor bed or resection bed at the time of surgery. So instead of having this time between surgery and radiation treatment, you actually deliver the radiation immediately. And it was used as far back as the 1900s, but it really fell out of favor due to side effects. And only recently has the brachytherapy treatment become more popular again because of introduction of new forms of radiation using cesium as a source of radiation, which has a better safety profile compared to prior forms. And so we evaluated, while I was at Cornell, a population of 80 patients that we treated with brain metastases with resection, treated with cesium brachytherapy at the time of surgery. And what we found was we had very good local control rates, especially in patients with non-small cell lung cancer and patients who were treated as a first surgery as opposed to a reoperation, with control rates of about 91% at a year. We also found relatively low radiation necrosis rates in this population, about 10%. And one of the advantages of brachytherapy is that, one, you're delivering local therapy at the time of surgery. So again, there's no interval period between surgical resection and radiation. So patients who may be lost to follow-up or who may not be reliable to follow up for radiation, you can treat them at one time with one surgery. In addition to that, radiosurgery, really one of the pitfalls of radiosurgery is that for large cavities or for large resection beds with irregular margins, it can be hard to design conformal treatment. Brachytherapy, as you deliver it directly into the resection bed, avoids that pitfall and difficulty with designing stereotactic radiosurgery treatment. So in addition to upfront treatment, brachytherapy is also being increasingly used for salvage surgery for treatment of patients with brain metastases who had previously been treated with stereotactic radiosurgery and have failed and progressed since that treatment. And then we go back in, do a re-resection of that recurrent tumor, and place the brachytherapy seeds at that time. And the literature is showing that in this salvage population, we're seeing pretty good control rates of 75 to 90% at 1 year, again with relatively low rates of radiation necrosis at about 10%. And we're also seeing that that compares favorably to alternatives such as resection alone, salvage resection alone, or salvage resection plus external beam radiation therapy. So brachytherapy is really becoming an expanding field within neurosurgical oncology at this time. And because of that, we're seeing a lot of clinical trials, a number of which we're running here at Miami Cancer Institute, evaluating brachytherapy as an upfront or as a salvage treatment for brain metastases. Now, another technology that's recently become increasingly popular is the introduction of laser interstitial thermal therapy, which is a minimally invasive technique where we can stereotactically drill a burr hole in the skull and introduce a laser probe into a lesion, whether it's deep in the brain or superficial, and using thermal ablation, ablate either a recurrent tumor or radiation necrosis, which is probably one of the most common indications for laser interstitial thermal therapy at this point. This is just sort of a treatment that we did while I was at MD Anderson, treating a recurrent tumor using laser interstitial thermal therapy, again, heating the tumor from within through a minimally invasive procedure. Now, probably the most common indication at the moment for LIT is to use it for controlling radiation necrosis. Many patients who have had radiation may have symptomatic radiation necrosis requiring long-term steroid treatment. Now, long-term steroids, as many of you know, have a multitude of side effects, and so LIT is being used as a potential treatment to decrease the length of time patients require steroid use. And this publication coming out of the Fecci group found that with just a hospitalization time of about 32 hours, a patient can have come off steroid use with a median of about 17 days compared to a much longer time if they weren't treated with LIT. And in addition to that, we're seeing that LIT can actually be beneficial for seizure control in patients with brain metastases and seizures preoperatively. So when you compare LIT treatment to alternative options such as medical management alone, patients in the literature have shown that with LIT, they can come off steroids within 37 days compared to over 200 days of steroid treatment with typical conservative medical management. In addition to that, if you compare it to bevacizumab or Avastin treatment, which is the other sort of standard of care for radiation necrosis, we see similar rates of improvement and weaning of steroids with actually somewhat improved survival in the LIT population compared to the Avastin group. Now, the last sort of surgical indication that I want to share and talk about for brain metastases is actually the treatment of leptomeningeal disease. So leptomeningeal disease occurs in about 3 to 5% of patients with solid malignancies, and it's basically the end stage of patients with brain metastases. It's when the tumor begins to spread within the CSF or cerebrospinal fluid spaces, and many of these patients can present with debilitating intracranial hypertension, with severe headaches, lethargy, nausea, and vomiting, and this can really prevent them from going on to any other treatment or even sometimes getting out of the hospital. So one of the treatments that has become more common is the use of CSF diversion or ventricular peritoneal shunts for patients who are presenting with symptomatic hydrocephalus due to leptomeningeal disease. Now, we evaluated a population of almost 200 patients who we treated with VP shunting at Memorial Sloan Kettering and found that survival is very limited in this population. Average survival after shunting was only about 2.5 months. But if you selected a population of patients who had a KPS greater than 60 or who had fewer than 8 brain metastases, we did find improved overall survival in that population. And 83% of patients did have symptomatic improvement after this treatment. And so with that symptomatic improvement, these patients were able to be discharged home in 70% of the population, and that allowed 50% of them to go on to get further systemic treatments. Now, as we improve our systemic treatment options, and especially as we introduce new treatment options for leptomeningeal disease, the idea of getting these patients out of the hospital and allowing them to get to another treatment becomes actually very important. So I've covered a wide swath of topics, and I sort of just hope that there are two main topics, or two main points that you can take away. One is that the prognosis of patients with brain metastases is improving, and that means that neurosurgeons, radiation oncologists, and oncologists alike have to come up with better treatment and local therapy options and salvage treatment options for these patients as they live longer. And we're seeing a growing number of opportunities within neurosurgical oncology to treat and help this patient population. So that's it, and thank you.
Okay, so thanks for everyone's attention. I'm sure you all agree it's been a real stimulating morning so far. The speakers have been excellent in every aspect. That goes without saying for our next speaker, Dr. Justin Sporer, who I have known for the past 11 years here at Baptist. I didn't realize it was that long. He's actually been entertaining me here for 11 years. For what I lack in the ability to tell a joke, he will make up for it, I'm sure, on this stage, I hope. Dr. Sporer is the Director of Functional Neurosurgery at Baptist Health Miami Neuroscience Institute. He received his medical training at the University of Florida College of Medicine in Gainesville. He's also a Gator, like I mentioned with Dr. Vasquez, and he completed his internship and residency there in neurosurgery as well. During his residency, he received the Charles Shank Award in Neurosurgical Excellence and Resident Teacher Award. He's a great teacher and a great lecturer, and was chief resident as well. He has special interest in deep brain stimulation, which is how he ended up doing our functional medicine program, which he's going to talk about today. And he's he'll talk about specifically high-intensity focused ultrasound and transforming treatment for essential tremors, which he's been doing a lot of great work here with HIFU. So really pleased to bring on our next speaker, Dr. Justin Sporer.
Thank you, Ron, and thanks for making fun of me that my CV was the shortest of all the neurosurgeons. And also, the last time I presented here, during a photo op, I fell off the back of the stage, which don't ask how that happened, but I'm okay. Today, we're going to be talking about high-intensity focused ultrasound, and if you get nothing else out of it, we can cure somebody's tremor in 45 minutes with no surgery. And functional neurosurgery is changing somebody's circuitry in their brain to improve the quality of their life, to improve the function of their brain. And so people with tremor, with Parkinson's disease, with dystonia, these various movement disorders, their brains aren't functioning properly. The neurons are not communicating properly, and it's our job, or my job, to make sure that they start communicating properly to improve their quality of life. No disclosures. So tremor. The most common diagnoses for tremor are actually essential tremor. There's 10 million people in the United States who have essential tremor. Compare that to 1 million people with Parkinson's disease, which I think gets a lot more press. But we all know somebody, probably our grandparents or even people younger than that, who have some shake, and you think, well, that's just a normal part of getting older. Another key point for today is it's not necessarily a normal part of getting older. It's something that is at least worth addressing. The other types are physiologic tremor, which everybody in the room has to a certain extent or another. And even the neurosurgeons, when you're under the microscope, everybody sees that their hands shake a little bit. We're just very good at accounting for it and adapting to it. Other causes would be multiple sclerosis, trauma, and stroke. The most common treatments are medication, medication, medication. I mean, that's where we should start. Even though I started by saying that we can cure it with no surgery, et cetera, I think it's worthwhile to start with medication. And in essential tremor, it's in the class of drugs of like neural depressants, okay? Propranolol, primidone. There are other options, though. Ultrasound. So, you know, everybody's familiar with the technology of ultrasounds. Existed for decades, both diagnostically and therapeutically. But at high intensity, the energy at a focal point, if you're aiming ultrasonic beams at one spot, the energy, the kinetic energy at that spot will actually increase such that the molecules will be vibrating and the temperature will raise, and then you can ablate tissues. And they've used that for decades to kill tumors of the liver and uterus. But in those cases, there wasn't much between the ultrasonic transducer and the tumor. We have a problem, though, with the skull as being in the way for treating problems of the brain. And so the big question during this time was, how do we maintain that energy and focus that energy to a very specific point in the brain? We're aiming at things that are 2-3 millimeters in diameter, while and able to actually affect a change. And so the skull absorbs energy, it also reflects energy, and it also refracts energy. And so every time that an ultrasonic wave, just kind of like a light wave, goes through from one medium to another, you're going to lose some of that energy, or it's going to be redirected into a different place. And so you can see here that the skull is made of 3 layers: an outer cortical, harder layer, a softer kind of medullary layer or bone marrow layer, and then an inner layer. And you can imagine each time that the energy passes through each of those layers, some of it's going to be absorbed, some of it's going to be refracted. It's kind of like yelling through a double pane window, glass, air, glass. And so it was a really a complex physics problem that I don't claim to have fixed, but some very smart engineers and physicists figured that out. And so here's the other brain problem. Let's say we figure out how to get ultrasound into the brain. Well, how do we know that the energy that we're introducing is causing a change in temperature at a very specific location in the brain? And it turns out that the answer is MRI thermometry, where I'm still amazed by this every time I do it. Every 3 seconds, an MRI machine can take a picture of your brain and know what's the temperature at every location in the brain every 3 seconds. And so it's like looking at a turkey in the oven and without a thermometer, just taking kind of a heat map of it and saying, okay, it's 176 degrees there, it's 200 degrees here. And so we're able to get real-time accuracy of knowing what is the temperature of every point in the brain. So we use an ultrasound machine to determine the energy that's being input. The MRI knows the temperature of every point. Okay, so now we know this point in the brain is 57 degrees Celsius. How do we know that that is enough to cause an ablation? Well, we use math and physics to determine that 57 degrees for 1 second is hot enough to cause a permanent ablation or burning of those neurons. And 54 degrees for 3 seconds is just like cooking. And so you can either do high heat for a small amount of time or lower for a longer period of time. And then once an ablation has occurred, how do we know if that's in the correct location or if that's having a clinical effect? Well, that's where we come in. The neurosurgeon can check for an effect by testing for tremor or testing for a lack of tremor, which is what we're aiming for. And so magnetic resonance guided focused ultrasound, or MIRGFUS, but it's much easier to say HIFU, which is high intensity focused ultrasound. And so you'll hear people talking about HIFU, and I really want to stress that we have an international audience here today. Even in Miami, it's hard to educate the general public and educate even the neurologists that this exists. And so I see patients all the time who come to me, they self-referred because their neurologist didn't know that this existed. And so it's such a wonderful option for people with essential tremor, particularly those who are not candidates for some of the other treatments. They can't get the medications because of their heart rate. They can't get deep brain stimulation because they're 92 years old and on blood thinners. So this is quite an amazing option for those patients. And so we're able to get the magnetic resonance guided part of it is the part where we're able to get a heat map of the target area and allows us to choose a very specific target. All right, so the target is the ventralis intermedius of the thalamus. I'm sure everybody is up to date with their neuroanatomy knowledge of the various subnuclei of the thalamus. But I think of it as like a small egg-shaped structure right in the center of the brain as a relay station. Remember in the old-timey movies where the operator had all the wires that were connecting one person to another on the telephone? Everything that you think, feel, do, say, move has to go through the thalamus at one point or another. And so the part of your brain that moves your arm, for example, that message has to go through the thalamus before it goes somewhere else. And so it's the relay station of the brain, which is interesting because then if you make an ablation at that subnucleus of the thalamus, you can have a big effect with a small ablation. All right, So I think of essential tremor as the perfect HIFU disease, all right? And the reason is because there's very few symptoms besides the tremor. Parkinson's, for example, is much more complex. You know, a person's got not only tremor, but rigidity, slow movements, problems with sleep, problems with smell, problems with their GI system, problems with walking. I mean, it's a complex set of symptoms. Essential tremor is just tremor. We know, and we've known for almost 100 years now, that the target in the brain is the VIM. And in fact, the idea of burning those cells is not new. I tell this to patients all the time. That's not new. We've been doing it. But in the past, you had to open up someone's skull in order to achieve that. So what's new is being able to do that same thing with no surgery. And tremor itself is a very testable symptom so that you can look for an immediate effect and, if necessary, make an adjustment. I believe, and I hope to be involved in, using this technology to cause ablations to help things like obsessive compulsive disorder, depression, various other neurologic maladies. The problem is, or one of the problems that we need to solve is, how will we be able to test for that immediately? Do you feel happy now? It's something that is kind of a longer term thing. Whereas the tremor, it's there one moment, and literally 30 seconds after the ablation, the tremor's gone. And so we're able to see exactly what we need to improve. You can see on the left, there is a sagittal view of someone's brain, and then on the right, I don't know if I can, up. Is there a laser on here? There we go. Maybe not. Anyway, you can see there is a black dot right in the middle of the thalamus. The thalamus is basically in the center of the brain. So that's the ablation. It's just that big. And it is able to stop and kill those neurons which are adding this extra message to every movement that you do. So I want to move my finger to my nose. Well, those tremor cells, they're literally called tremor cells, are adding this extra rhythm to that movement. If you kill those, so I use the word ablate with patients. Kill has a negative connotation, of course, but I'm very open with them. We're killing those neurons. They're not doing you any favors, okay? And so that's the post-op MRI. What I really like is that it allows you to do a test drive. And so you can introduce the ultrasound at a lower dose and heat up those cells. Remember I mentioned 57 degrees. Well, it turns out if you raise the temperature to 51 degrees or 52 degrees, the neurons are stunned. They stop working, and the tremor goes away. But they're not dead yet. And it's just like if you put ice on your hand, it'll go numb. But as soon as you take the ice away, the neurons heat back up, and they start working again. Well, it works in the opposite direction, too. If you heat up a neuron and it can't function anymore, then you see, well, what did that neuron do? So we'll introduce the ultrasound, we'll raise it to 51 degrees, and I'll go in and examine the patient over and over again. If their tremor is getting better, well, what does that tell me? I know I'm in the right location. Then I feel confident to go back out to the machine and turn up the energy to cause a permanent ablation. On the other hand, if I raise it to 51 degrees and the person says, "Doc, I feel some tingling in my mouth and my speech is a little bit off," which happens, then I say, okay, and I use my knowledge to say, well, I think we're about 2 millimeters behind the target that we want to be. And so I just change it, and nothing permanent has happened yet, so it's a test drive. So somebody had this idea, what if we kill these neurons with radiation in the past, with stereotactic radiosurgery? It's a great treatment, except once you've delivered that radiation, that's it. There's no going back, and you won't even know if you were right or wrong for weeks or months by the time the radiation effect kicks in. And so I like this better because you are able to test drive it right there, see what the effect is going to be, and that's it. And so I'll have the patient drink from a glass, draw a spiral, write their name, finger to nose. So this is, I have the patient try to start at that center dot with a marker and stay in between those lines. And that's the effect. Can you imagine somebody trying to shave their face with that kind of tremor? Or use a mouse. This is another one that's kind of a more modern example. So people say, I'm buying things left and right on Amazon that I didn't intend on buying because they're clicking the wrong thing. And I've seen people, they put their arms up against the wall to shave their face, they just move their head because they can't possibly move their hand to do such a fine motor task. Women with putting on mascara, forget about that. But the number one complaint is embarrassment when I'm at a restaurant. And so, you know, I think of all of my colleagues, probably embarrassment is not the number one complaint that they're operating on complex aneurysms or brain tumors, et cetera, but it's my number one symptom. And, you know, because it's so safe, that's a reasonable reason to do a procedure. And so I think that once we've done the procedure here, this is their spiral 45 seconds later. So it's just so satisfying. It's really satisfying because the patient's like laughing or crying and we're like high-fiving, et cetera, and then they go home. They go home that day. So it's a really fulfilling procedure. The advantages, it's non-invasive. There's no surgery. You take blood thinners, that's okay. You're 95 years old, that's okay. You have breathing problems, that's okay. It's not a surgery. So if you can undergo, I wouldn't even take colonoscopy because that has some level of anesthesia. If you can get a cyst removed from your arm, then you can do this. No hardware to worry about. And I mention that because I also do deep brain stimulation, which I think is a wonderful procedure for people with Parkinson's and a lot of people with essential tremor too. But for whatever reason, you know, people really don't want this piece of hardware in their body. And the batteries need to be replaced, et cetera. The test drivability, we talked about that, and it's super effective. It's super effective, and 45 minutes to an hour later, the tremor's gone. Drawbacks, you do have to shave your head. I see some people in the room that are already ready for the procedure. It's not an easy alternative. So some people say, I don't want brain surgery, I want HIFU. I say, listen, I mean, those 45 minutes where we do have to put a head ring on them, we have to shave your head. During the procedure, you can have a feeling that you're like falling backwards. It can be an odd experience, but people tolerate it fine. I guess that's more of an endorsement of the deep brain stimulation, which is also not that big of a deal compared to what people think it's going to be. And then temporary numbness of the face and hand, temporary imbalance, those would be the top two side effects. Remember, we're making an ablation in this relay station that controls everything. So the analogy that I use is that if I put a cigarette out on your skin, I promise I won't, but it's gonna look like just the tip of that cigarette. But if I look at it the next day or 2 days afterwards, it's gonna be all red and swollen all around there. And the same thing happens in the brain. I'm making about that size ablation in the brain. The day after and the day after that, there's some swelling which causes some dysfunction of those neurons. But I tell them, hey, listen, if these things show up on day 1 and day 2 after, then I'm very confident it's the result of swelling. And as the swelling recedes, the tides go back out, those neurons will come back to normal. So I strategically have the patients follow up about 2 to 4 weeks after the procedure so that all their negative feelings towards me are gone and their side effects are gone, and it's just the tremor suppression that they're left with. This is just, you know, for a long time people say, well, okay, well, what's the long-term result? This is the 3-year results, and we now have actually 5-year results. I need to update the presentation. It's still 76% improvement in tremor on average, and that includes some rare people who don't get benefit. I would say the people that don't get benefit, it's because we're never able to achieve that temperature. It's not that it didn't work, it's that for whatever reason their skull did not want to allow that ultrasound in. Well, if you don't actually achieve what you set out to achieve, it's not going to have the effect that you want to affect. But on average, 75, 76% improvement in tremor, which can make a huge difference in those, you know, restaurant-type situations or makeup situations, or how about eating and drinking at home even. So it has a lasting benefit. This is a video of a gentleman on the left before and after. Lady before and after. And the difference between those two things could be, like I said, about 45 minutes. You can see she's got a shaved head, though. I'll go back and play it again, just so you can. So I think the marketing group got together, and they always give our patients a lunch afterwards with soup, with like these ultra full glasses of water. the game operation. So, you know, just to show exactly how much better it is instantaneously after the procedure. So the final points. Tremor is not just a part of normal aging. So if you know somebody who's got a tremor, whether that's in your family or in your practice, et cetera, I think it's worth at least addressing. And that's either with a movement disorders neurologist, or if they've already got a diagnosis, then with the neurosurgeon. It can be treated first with medication, but HIFU, high intensity focused ultrasound, it's safe, it's FDA approved, it's very effective, it's covered by most insurances at this point. And more recently, we've used it for things like Parkinson's disease, and there's research being conducted for, now the second side has been approved, other movement disorders, and even psychiatric conditions. Thank you. And that's my email.
That was exciting research, exciting knowledge, and what we're doing here at MNI and with Dr. Sporer is great. We used to call Dr. Sporer the king of kyphoplasty, or king of kypho, and he still is, but now he's also the king of tremors. So, and if you ever see him socially, you might see he can also be the king of the dance floor. So thanks for a great presentation. Our next and our last speaker for the morning before our question and answer panel is Dr. Luis Felipe Tornes, who's also one of our newer physicians in the group under neurology. Dr. Tornes is our director of the epilepsy program at Baptist Health, Miami Neuroscience Institute, and he earned his medical degree from Florida International University, Herbert Wertheim College of Medicine, so he's a Panther initially, and then he completed his neurology residency and a clinical neurophysiology fellowship at the University of Miami Miller School of Medicine, so he's also a Kane, so I'm not sure where his allegiance is right now. I'll have to ask him that. He has presented at national conferences in his field and specialty in American Academy of Neurology and the American Epilepsy Society. He's passionate about comprehensive care and holistic care. He's also our residency director in neurology, so we're very pleased to have our first neurology residency starting here in conjunction with FIU and Baptist, and they're currently interviewing for 4 spots in neurology now. So it's with great pleasure that I bring up Dr. Tornes, who will talk to you on epilepsy, the new era of diagnostic and therapeutic intervention. Dr. Tornes.
So thank you all for having me today. Thank you for Baptist International for setting this up. I will say I'm probably a little bit more of a Cane just because the Canes are a little bit better than FIU. And also the Canes played FSU and UF this year, and we won both of those games. The season didn't end up that well, didn't make the playoffs, it looks like, but otherwise it was a good season for us. So I'm going to be speaking to you today about basically management of epilepsy patients. In particular, more medical management. I'm a neurologist, not a neurosurgeon, so let's see. So I have no disclosures. So today we're just going to be talking about epilepsy statistics overview. We're also going to be going over the definition of what drug-resistant epilepsy is. We're also going to be just quickly touching on epilepsy surgery. And then really the majority of the talk is going to be on cenobamate, medical management of drug-resistant epilepsy, going over the mechanisms of actions of the medication, also kind of what are the adverse events that you should be expecting when you start patients on this medication, the more common ones and the ones that you really should be worried about, and also how do you use this in your daily practice. Really the point I want to get across in today's lecture is in epilepsy and in medicine in general, there's always new medications coming out, and it's kind of introducing this new medication into your practice. How do you use it? So that's kind of really what I want to get across today and why we should be using it. So for statistics. So within the United States, from the last census in 2020, there's around 331 million people. Per CDC, around 1.2% of the population in the United States has epilepsy. So that's a little less than 4 million patients with epilepsy in the United States. So it's a pretty large percentage of patients. It's something that we see pretty commonly both in the inpatient side and also in the neurology clinic. So I like to show this slide, and maybe some of you have seen it before, but just kind of going over all the medications there are in epilepsy and how much there's been in terms of growth of medications in epilepsy. So as you can see on the slide, and I'm sure none of you have probably ever used this medication, bromide was the first one that was ever used in the 1800s. But if you look at the next medication, phenobarbital, I'm sure some of you have used that medication before. That was kind of really the first one that was created in the 20th century. And then you could just see the exponential growth after that. All these new medications going through that first generation, the second generation, the third generation of anti-epileptics, and really more and more that continue to come out. But despite all these new advancements and kind of options that we have in these anti-seizure meds, there still remains a portion of your patients with epilepsy who have drug-resistant epilepsy and will continue to have seizures despite this. So what exactly is drug-resistant epilepsy when you hear that term? And it sometimes could be phrased in another manner. It might be referred to as refractory epilepsy, intractable epilepsy. Really, it's all the same. And what it means is, per the International League Against Epilepsy, which I think is one of the best names in medicine, that's a great name, they define drug-resistant epilepsy as someone who has failed to become seizure-free after being adequately trialed on 2 separate anti-seizure medications. So if you have a patient been tried on 2 appropriately dosed medications for seizures and they continue to have seizures, that's defined as drug-resistant epilepsy. So this is another chart that probably some of you have seen if you're familiar with epilepsy. It's one that I really like because it kind of breaks down what's the chance of your patient having drug-resistant epilepsy, or what's the chance of your patient responding to medications when you start them on it. So as you can see on the graph, in the pie graph, when you start someone on the first anti-seizure medication that's coming into your office for epilepsy, you've determined that you have epilepsy, you need to be started on a medication. When you give them that first medication, there's only around a 50% chance that they're going to remain seizure-free from that first medication. If you were to add a second medication, you see that's a 13% increase. So now you got yourself a little bit higher. So here in this chart, you'd have yourself around 60%. If you add a third medication, now you have yourself maybe at 64% of the population is going to be seizure-free. That still leaves you with 36% of your patients who are going to continue to have seizures despite being on 3 medications. And as you add more and more medications, that percent of seizure freedom gets lower and lower. So why is it so important to really discuss this? Why is drug-resistant epilepsy important? Why is it important to get seizure freedom? Well, the reason is because there are complications for your patients if they have drug-resistant epilepsy, and having seizures really is something that can have a detrimental effect on the person's life. So each year, around 1 in 1,000 patients with epilepsy will die from sudden unexpected death in epilepsy, SUDEP. And the risk of that is increased in patients who have poorly controlled seizures. So people who are having multiple seizures, more so in generalized epilepsy, but people or focal to secondary generalized epilepsy, you want to have your patient well controlled, because if they're not, they can increase the risk. Also, having uncontrolled epilepsy has a higher risk of death and overall mortality secondary to seizures and suicide. It also reduces your quality of life, cognitive functioning down the road, anxiety, depression. All of these factors are associated with poorly controlled epilepsy. So it's something that you really should be working with your patient. Just for example, in Miami, it's really hard to get around Miami without being able to drive. And in the state of Florida, if you have a seizure for these patients, they can't drive for 6 months. So that can be really detrimental for someone and can really have a huge impact, just that alone, outside of all these other things I just mentioned. So it is really important to achieve seizure freedom for these patients. It can really make an impact in their life. So what do we do with these patients? So someone comes to you, they're on 2 medications, maybe 3 medications, they continue to have seizures. What are our options? Do we continue to add meds? Do we change the meds that they're currently on to try different options? Do we refer them to surgery at that point? Or do we do nothing at all? Do we just say, well, there's nothing really you can do. You've already tried a couple meds. The percent chance of seizure freedom is low. You have all these side effects. We're just going to kind of be happy with where we're at. So I would say that the best thing to do for these cases is surgery. And that's still the gold standard. That's still what you should always be aiming for. For people with drug-resistant epilepsy, surgery is going to be their best option to have seizure freedom. So the study's kind of looking at this, and in seizures in general, for surgery, the best case is a temporal lobe epilepsy. Non-dominant would be ideal. And in those, in terms of resections, not necessarily because I know they had spoken about earlier, and that is something we do a lot, laser ablation, but specifically in resective surgeries, there's around a 70% seizure freedom following a resection from a epilepsy secondary to a temporal etiology. So that's a really high percent. So again, if you kind of look back at that chart, you think back at that chart what we discussed, where someone comes in on 2 medications, if you're going to add a 3rd medication, you only have around a 4% chance of seizure freedom. Here is 70%. So that's a huge difference. And that can make a huge impact, because not only, let's say if you were to add that 3rd medication and they fall into that 4% that, okay, now they're seizure free, but they're on 3 meds and they're going to have all the side effects from those meds. So being able to get them surgery, you might be able to eventually get them on monotherapy, maybe even get them off of all their meds. So that's still the best option. For people who have non-temporal etiology epilepsy, it's still a high chance. It's still 62%, which is still much better than that 4%. So this should still be the gold standard. All your drug-resistant epilepsy patients should be referred to surgery. The issue is that what if your patient can't get surgery? They're not a candidate for surgery. Either their seizures are coming from an eloquent cortex, something you can't resect, or they have multifocal epilepsy, so you can't really resect the multiple areas of the brain. You have neurostimulation is another option. So you have the deep brain stimulator that was mentioned. We also use that in epilepsy. Responsive neurostimulation. We have the vagal nerve stimulator. But again, those are more palliative options. You're not going to get seizure freedom with those, but they're options that still you can use if patients aren't a candidate for surgery. But what if they're not a candidate for surgery, they're maybe not a candidate for neuromodulation, or in some areas, there's just not an option for surgery? There are some places where you can't refer someone to a neurosurgeon. A lot of times, the epilepsy workups have to be done in a large center with an epilepsy department, a neurosurgical department. They need an EMU. It's sometimes now, especially in the world of epilepsy, there's phase 2 trials where you're putting in depth electrodes to really localize where the seizures, and a lot of places aren't able to do this. So what do you do for these patients that, well, I can't do surgery on you, or maybe, again, just due to the lack of care, even if you're able to do it, it might be a year before the evaluation is completed. What do you do between that time where the patient's having all these seizures or they can't get surgery? And that's where I think cenobamate comes in. And I think it's something that's kind of changed now how we're starting to practice a bit in the world of epilepsy. So what exactly is cenobamate? So it's a medication that was FDA approved in 2019 for focal seizures in adults. It's a voltage-gated sodium channel blocker. And I know for you familiar with epilepsy medications, the vast majority of them are voltage-gated or sodium channel blockers. But this one's a little different because it, in particular, inhibits the persistent sodium currents. So most of the other ones don't inhibit that part in particular in the sodium channel. So that's what makes it a little bit different. And also, it's a positive allosteric modulator of GABA A as well. So it's most protein binding of around 60%, so it's not too protein bound compared to some of the other medications. It has a half-life of around 50 to 60 hours, so you can dose it once a day for the patients, which is nice. It's convenient for them. With regards to the adverse effects, it does have similar adverse effects to most of the other sodium channel blockers that we use. So lightheadedness, dizziness is going to be a common complaint. Fatigue, which you kind of see across all anti-seizure medications. Another one that you have to be kind of keep in mind is it can shorten QT intervals. So people with familial short QT syndrome, something to keep in mind that could be dangerous. And then the one that I think people really think about in terms of adverse effects and the one that kind of scares you as a doctor is the drug reaction with eosinophilia and systemic symptoms, so DRESS. This was something that was seen on the initial trials when cenobamate was being introduced. And there was even one patient in the trials with a fatal case of eosinophilic myocarditis. When they went back and looked at the trials and saw kind of why was this going on, they realized that it was probably due to the fact that they were starting these doses at the medication, the cenobamate, at probably too high of a dose. So now cenobamate is recommended on a slow titration, kind of similar to what you would do for your patients with lamotrigine to prevent Stevens-Johnson's. So they recommend the same thing. And when you do that, when you do this slow titration, it really has a low risk of DRESS. And there haven't really been any cases when they went back with the slow titration of fatal eosinophilic myocarditis. So while yes, it is something that doesn't completely eliminate it, doing the slow titration, it isn't something you should be too concerned about, but still you always have to discuss this with your patient and let them know that it is a potential side effect. The other one that really is also important is really the interactions with the other medications. And that really comes to how we use this in our clinic, how we're using it in practice. Again, this is a patient who has drug-resistant epilepsy. They're going to be on 2 medications, maybe 3, maybe 4, maybe 5. I have patients 6 medications, and you're starting a new medication, cenobamate, on them. It's going to interact with a lot of these meds. So you have to be familiar with the interactions and how you have to kind of go about handling that. And so why am I talking about cenobamate? Because I've just told you all this kind of, well, you should do surgery, the chance of seizure freedom is really low, there's no point of medications. And yes, you should still do surgery on all your patients. Surgery is always the best option for drug-resistant epilepsy. But this is why I think this medication in particular is so interesting in the world of epilepsy and kind of has changed how we approach some of these cases. So if you look here, and this chart here is showing the efficacy of the medication, so kind of what the reduction in seizures were in the initial trials of cenobamate. And if you look all the way to the end of the chart at the 100% response rate, that means that that person was seizure-free. If you look at the group that was on 400 milligrams, so that kind of pinkish color one, that was 21% of patients. So 21% of patients that were started on that medication, drug-resistant epilepsy, were seizure-free. So if you compare that to that 4% I showed you earlier, that's a big, big difference. So this is the first medication that's really started to kind of buck the trend of what we used to see, where you introduce a new medication on these patients who have been on 3, 4, 5 meds. It has a much higher rate of seizure freedom in these patients. Again, nowhere near what it was for surgery. I already showed you that 70%, still much lower. But this is still a great option for these patients who maybe can't get surgery or are in the process of getting surgery and it's just taking time. A lot of places, it's not easy to get the surgery workup. You have to come in for your EMU admission. You got to get your MRI, neuropsychology testing, PET scan. You might have to get a MEG. You might have to come back for a phase 2 with the depth electrodes. By the point that's all done, it might have been a year already by that time. So being able to put these patients on this medication in between could be something that you can consider. And then this one here, just kind of looking at the efficacy onset. So again, you can see here that in the first 4 weeks there, it's already showing efficacy. So you should already be expecting a response pretty quickly with this medication. It's not something that takes particularly long. The only thing I will say that here, again, in this chart, is showing at 100 milligrams. And once you're already on 100 and then 4 weeks after that, in general, you're not going to be starting your patients. Do not start your patients on 100 milligrams of cenobamate. You're going to be starting them on 12.5 and going up on that slow titration. But once you have them on a therapeutic dose, the response should be pretty quick. So then, kind of more sort of the practice, how are we using this? And this is the one that I like to focus on because it's the one where if you're starting someone on this medication, what you should be really considering. So unfortunately, the medication does have a lot of interactions with other anti-seizure meds, which makes it sometimes a little bit difficult to introduce for patients. So the ones that you should be keeping in mind, it is an inducer of the CYP3A4 and CYP2B6. So for those two in particular, it's going to be decreasing the concentration in the serum of lamotrigine and carbamazepine. The one thing about that is it actually might be beneficial for your patient because, again, those are both sodium channel blockers. Cenobamate is a sodium channel blocker. Your patient's probably going to have a lot of side effects from sodium channel blockade. They're going to be complaining of lightheadedness and the dizziness. So the medication decreasing the levels of those two might be beneficial in decreasing the amount of symptoms that your patient has. The one that's a little bit more important that you should be thinking of is the CYP2C19, which is going to inhibit that. So it's going to increase the levels of phenobarbital, phenytoin, and clobazam. So your patients, when you start them on cenobamate, the levels of those medications are going to go up. So they might become toxic. They might start having side effects from those medications. So it's something you have to keep in mind. And while there's no pharmacodynamic or pharmacokinetic interactions with lacosamide, there are pharmacodynamic interactions. So basically, the lacosamide level isn't going to really change by introducing the cenobamate into your patient's regimen, but they're going to have a lot of side effects from the lacosamide. It intensifies those side effects. So if you have a patient on lacosamide and you start them on cenobamate, the level of lacosamide isn't necessarily really changing, but they're going to be complaining a lot of sodium channel kind of blockade side effects, that the lightheadedness and dizziness is very commonly experienced. So because of all of these interactions that this medication has, they actually went about, this is actually really nice. It's a little basically pocket guide. And that little dash in the middle there that you see I cut it out, but it says fold here because it's basically like intended for you to carry it with you. So what they did was they had basically they got a group of 7 epileptologists to come up with how should neurologists use this in practice? What should they do? So here what you can see is basically they broke it down and they've made it as easy as possible to what should you be doing with these medications that the patient is on when you're introducing cenobamate. So there's 2 ways you can go about it. You can be proactive or you can be reactive. And just to take, for example, the clobazam, so if you have a patient on 40 milligrams or less per day, you can be proactive and go ahead and start to decrease by 5 to 10 milligrams per day at the start of cenobamate, 12.5 milligrams a day. So, and then you can see kind of the proactive, it continues. You can go down again by 5 to 10 milligrams a day when you hit 50 and then again, or you can be reactive. And what they mean by that is basically you don't touch the clobazam, you don't touch some of the meds, and you just wait to see what happens. You start the person on cenobamate. If they're coming back to you and saying, I'm really drowsy, I'm really sleepy, well, maybe you start to come down on that clobazam. Because again, Clobazam, while it's not as sedating as other benzodiazepines, it's still pretty sedating compared to most anti-seizure medications. So you can kind of be that reactive. The same for lacosamide. Here they recommend, and I'm sure most patients, if you look here, most of your patients are probably going to be on 400 milligrams a day, which is 200 BID. In this case, they tell you to be reactive, so only really make adjustments if your patient's complaining of symptoms. Similar to phenytoin and phenobarbital, you can kind of see they have it all broken down on what you should be doing as you're going up if you're being proactive, or what you should be doing if you're being reactive, and just making adjustments as the patient starts to explain that they're having those particular symptoms. I will say in general, I do like to be proactive. I think it's nice to just kind of get ahead of the side effects, because as a lot of you may know, if you treat epilepsy patients, one of the biggest concerns for a lot of medications in general is how compliant the patient's going to be. A lot of times, a year down the road, they might not be taking their medication anymore, not because they're having seizures, but because they're having a lot of side effects. So if you start them on cenobamate and they stop it because, well, they're dizzy, they're lightheaded, they're sleepy, you've kind of maybe prevented them from having a fair chance of being put on a therapeutic dose, because again, you have to go through that slow titration, but right off the start, you might start to have side effects, and they might never get up to that dose which is usually 200 milligrams a day is what they recommend to kind of start a patient or target to. So then you might have the patient stop the med before then, and you don't give them the chance of really seeing if cenobamate was beneficial for them. So this is really nice. It's easily available. I definitely recommend anyone who's going to be using cenobamate to grab this chart and use that, because again, a lot of these patients, they're going to be on 3, 4, 5 meds when you're introducing it. And just quickly to mention, so while it's not FDA approved, there is use of cenobamate for generalized epilepsy as well. There have been some trials looking at does it help, and some of the initial trials have shown that it does help for generalized epilepsy, and a lot of patients who have focal and generalized epilepsy. So if you just want to be really strict by the guidelines and you say, I want to just use cenobamate for FDA approval, I'm going to use it to treat your focal epilepsy, but you also happen to have generalized epilepsy, studies have also shown that it's not going to worsen the person's generalized epilepsy. It's not going to be like a carbamazepine. You start patient that has both, and then their generalized epilepsy gets worse even though you're treating the focal epilepsy. So in summary, around 1/3 of your patients will have drug-resistant epilepsy. Surgery is always the go-to option. It's still the gold standard. They should all get a surgical evaluation if they have drug-resistant epilepsy. If surgery is impossible, or maybe the workup is taking too long, that's where you should be considering maybe cenobamate as an option as well. It's FDA approved for focal epilepsy. I'll mention it again, non-FDA off-label use for generalized epilepsy, and it has been shown seems to help. Around 21% seizure freedom, so that's much higher than what we've seen with prior anti-seizure medications. It does have a lot of interactions with meds, so just keep that in mind. That chart, use it. Your patient's going to have side effects, so go ahead and start making lowering the other meds to make them comfortable. And then just the slow titration. The packaging is done very easy. It kind of comes in the titration schedule, so it's very straightforward for the patient, and that really lowers the risk of DRESS or other of these severe complications. These are my references, and thank you. Okay.
Thank you, Dr. Tornes. Great job. And I would like to now invite all of the speakers from this morning up on stage in these white, cushy seats. All of them but Dr. Vasquez had to go to surgery, so he won't be joining us. So if there are questions for him, we can certainly hold those questions, give them to him, and get contacts from you and get you those answers. Or one of the other surgeons can chime in. Also, I should mention that Dr. Sporer has to go to surgery shortly.
It's okay.
It's okay? All right.
We can wait.
All right, so we're going to open up the question and answer session and we have people going around the room with microphones, and we'll come to you to answer your question. We have a gentleman in the front with a question. The microphone's coming to you now. And I want to compliment all the speakers today for such a fabulous job. I think you'd all agree.
I am Luis Bracamonte from Lima, Peru. I'm cardiovascular surgeon. Dr. Dabus, can you explain a little more about your last treatment, the conduit between carotid and femoral vein, and where are the indications for this type of procedure?
Perfect, absolutely. So basically your question is, indications on how the TCAR, which is transcarotid artery revascularization, works. So first of all, indication. So So if you look into the Roadster 1 and Roadster 2 studies, those are the studies that were done as a registry to look into the safety and the effectiveness of the procedure. So the procedure actually was remarkably effective and remarkably safe. Actually, their numbers, which are adjudicated independently, are actually probably better than a lot of the other studies from comparative techniques. But of course, it's very hard to make a distinction between TCAR and carotid enterectomy or carotid transfemoral angioplasty and stenting, because those were never really like randomized studies against each other. But right now, actually, most of the patients that are candidates for revascularization are candidates for TCAR. Some of the contraindications for it would be similar to a transfemoral carotid stent. For example, a patient that for whatever reason cannot be on dual antiplatelet agents, because that's required when you put a stent, independent if you're doing transfemorally or through the transcarotid. Sometimes, if the patient has very tortuous common carotid, very short neck, it may be a little bit difficult. Exactly. I mean, there are ways to do it, and a lot of people with more experience now are doing pretty much for a lot of the patients. If you look into, even if you look at our numbers here, TCAR took a lot of the volume from endarterectomy. A lot of the younger vascular surgeons are preferring to do TCARs. You know, it's a little bit less invasive. The patients are doing very well from it. It's very simple, the technique. So the technique is basically a carotid exposure, a little ligature in the proximal common carotid. You put a 9 French sheath, which is a specific sheath from a company that makes the device. And so you connect the sheath, you kind of basically suture the sheath in place in the chest really quick. And then you get a 9 French femoral vein sheath that you put in the femoral. You basically connect the cable. The cable has a little filter in between. And basically, when you're ready to do the procedure, you basically ligate the common carotid just proximally, so you have true flow arrest, and then basically reversal flow. And then the procedure, literally, like the angioplasty and stenting part, it's really the easiest part of the procedure. I mean, it literally takes like 5 minutes. Put the balloon, inflate, put the stent, and you're done. You wait about a couple minutes with flow reversal. You untie the ligature of the common carotid, suture the orifice in the common carotid, the puncture site, and that's pretty much it. And the procedure is done. It literally takes less than an hour to do it. So again, the indications of it are pretty much all the patients, as long as they have good anatomy to do it, they would be a good candidate. Of course, there's always questions about, oh, if you have a very calcified lesion, you know, usually those are not very good for any kind of angioplasty and stenting. Maybe, you know, it would still be preferred to do an endarterectomy. But other than that, it's really any patient is a candidate for that. And we do that in conjunction with the vascular surgeons for many years here. It's a very good procedure. Nowadays, actually, a lot of the procedure are done just by the vascular surgeons. It's very straightforward. And literally, the patients like it. A lot of times given, like, you know, TCAR, transfemoral carotid stent, if the patient has a very bad arch or very tortuous proximal carotid, or sometimes a very tortuous common internal carotid artery, because when we do transfemoral, we need to put a filter there. And if the patient has a very tortuous, very loopy internal carotid artery, it's usually not a good idea to try to navigate the filter through it, because the filter is fairly stiff. So TCAR would be a great option for that as well.
Thank you. Next question.
Hello, I'm Dr. Abad from Quito, Ecuador. I run the epilepsy center over there. Just want to make a quick question to Dr. Tornes. What's your experience using deep brain electrodes versus cortical grids in successful rates in surgery?
Yeah, so for the phase 2 grids versus depth electrodes, I will say that my experience is much more so now in depth electrodes, and I do think it is something that most places in the United States, most of the larger surgical centers have started to move towards. I do think they both have their pros and cons. I do think for the actual localization, depending, especially on the deeper structures, the grids are not as good, in my opinion, as the depth electrodes. Also, the depth electrodes are less invasive than placing a grid. So I think now for most places, they've started to move away from grids, and most cases are being done purely with depth electrodes, with the very rare case including a grid if necessary. Because you can even use the depth electrodes for mapping as well. You can stimulate the electrodes. There are also other uses of electrodes that's starting now to be used in the United States, where Kind of in Europe, you were seeing thermal coagulation with the electrodes as well, the depth electrodes, which now a few centers are starting to do that within the United States. So if you do a phase 2, you plant the depth electrodes, you have an area where you think the seizures are coming from, you can actually right there before you remove the electrodes, thermal coagulate the area, remove them, and then see before they come back in for their resection or what you were planning on doing, well, did we cure them of their seizures? So I think the depth electrodes are probably the better option. I know in a lot of other places outside of the United States, especially in Europe, it's something they've been doing, and I know in France and Italy in particular, they have a lot of experience with depth electrodes, way more than we do here in the United States. They've been doing it since the 70s, I believe. So I do think that seems to be kind of the future now, is moving away from the grid and more towards depth electrodes.
Thank you. Another question. Yes, sir. Front.
To Dr. Dabus. It's about the stenosis of the carotid artery. The prevalence of coronary arterial disease in this patient is higher. Do you study the coronary's anatomy before the procedure? And what do you do when what are the kind of lesions in the coronary arterial tree that you decided to treat before to treat the carotid stenosis?
So thank you very much for your question. I think that's a very interesting question. Basically, depends a lot on the patients. A lot of our patients here, particularly when we're consulted in-house, they do get evaluation by cardiology to make sure. And the reason for that is that for many, many years, we were basically splitting those patients if they were high risk or not cardiac-wise. And why is that important? Because of the smaller increase in risk of MI during the arterectomy. So a lot of those patients would be basically evaluated by cardiology to define if they would be considered high risk or low risk for endarterectomy. So if they were like low risk, these patients would go all to endarterectomy. And if they were high risk, they would be referred for either angioplasty and stenting through transfemoral or transcarotid route. But a lot of this, unless the patient has a strong cardiac history, then maybe they would require like a stress test and see or even like sometimes a coronary angiography to see if they need to have anything done before those type of procedures. A lot of it is just based on also on the risk factors and risk profile. And they would be enough, for example, if the EKG is normal, the patient doesn't have any symptom, they would just consider this patient a low risk because it's kind of a low risk profile. So yes, I mean, it's always an interesting question, but if the patient was considered high risk from the cardiac perspective, it's not that he would necessarily intervene ahead of time unless there was like symptomatic, of course, asymptomatic not. And then the patient would be referred for angioplasty and stenting. Now, the reason why a lot of this was done is because until last year, the healthcare system here in the United States was only reimbursing either carotid angioplasty and stenting and TCAR if the patient was high risk for endarterectomy, was the main, and symptomatic. So now these things change. So a lot of the patients are just not necessarily going to the endarterectomy because there are other options that they may be going forward. But we still always get clearance from cardiology to make sure this patient is not high risk, or if it is high risk, if there's any other precaution that needs to be taken.
Thank you.
Dr. Torms, as far as localizing where the source of the focus of epilepsy is PET scan, where's the place for PET scan versus MRI, or are both complementary?
Yeah, that's a good question. So I think they're both useful. They both have their places, and especially now where you're seeing a lot of more cases of these epilepsy, drug-resistant epilepsy patients who are coming in and they're not the textbook mesiotemporal sclerosis on MRI, which everyone loves to see because it's a super easy case. I think a lot of patients now are coming in and they're what we're calling non-lesional epilepsy. So PET scans play a role because you can have decreased uptake in an area where maybe on the MRI, it showed nothing. So I think most cases, and kind of from what I do and what I've seen a lot of people do, is you use both. Both of them can be helpful. They can give you different information, and that's in conjunction with all the rest of the workup you're getting in your phase 1. So does the PET scan match up with the semiology? Semiology, well, yeah, we have a lot of fancy studies now with the PET. We have MRI, we have depth electrodes, we have MEGs. Semiology is still keen, so does your semiology match up with what you're seeing on your MRI? Does it match up with what you're seeing on your PET scan, on your MEG, on your scalp EEG, on your depth electrodes? So I think it always plays a role and can always add additional information to your workup. So it's something that if possible, I like to have all my patients get a PET scan in addition to their MRI.
Thank you. Next question. Okay.
Dr. Ina Miller from Honduras. Dr. Dabus, I'm curious about your asymptomatic pool of patients. What is the usual workup for, for that patient to arrive to that diagnosis and for you to consider treatment?
Perfect. So, we live in an era that a lot of the patients come in with any kind of neurological symptom that may not be even related to anything like dizziness or headache and all this kind of stuff. They come to the ED or they go to their primary care physician, and it's almost, a lot of them get ordered neuroimaging like CTA, MRAs, and things like that. So a lot of those are found like that, are incidental findings, right? Because they're asymptomatic. They're not having symptom related to the carotid. The other, a lot of those patients are also referred from basically their primary care offices or cardiology offices where they do like annual screening with carotid ultrasound, and they pick it up, and then you start a workup. Now again, the workup is, a lot of times you get a patient with a carotid ultrasound, then you go to a little bit more detailed imaging, usually non-invasive first, either an MRA or a CTA. And then you need to have a discussion about the patient, well, first of all, you need to understand what's the degree of stenosis that you're dealing with, and then, expose really both options of the coin to the patient. There's really no clear data that tells you that you need to be treated if you have like a 70% stenosis, for example, although there's no randomized data that clearly tell you that medical management or treatment with either surgery, TCAR, or angioplasty and stenting should be done preferred against the other method. However, we always explain that there's some new data, some new evidence that the degree of stenosis will actually potentially impact the risk of stroke, even if they're asymptomatic now. So it's a very open discussion because there's no randomized trial that tells us exactly what needs to happen. However, when the patients are put that way and the patient has an 80% stenosis, for example, that is asymptomatic, and they understand that the risk of them having a stroke is about 3 to 4% per year, a lot of them prefers to get treated. So it's almost like a discussion, and it's really a combined decision. Now, of course, if the patient has 75% stenosis, very elderly, asymptomatic, multiple comorbidities, that takes into account if you're going to do an invasive procedure in a patient like that, because that's going to be potentially some extra risks involved. So it really depends on the whole scenario, because we don't have the clear data that probably will come with CREST-2. That will be really the decisive data that tell us, oh yeah, this patient needs to be treated this way or that way. And we look forward to those results.
Thank you. For some of the other panelists, Dr. Sioman, when would a non-neurosurgeon or non-neurologist send you a case when, for example, a primary care physician does an MRI on a patient for headaches or dizziness and finds an aneurysm? Would you want them to come directly to you, or would you want them to have a particular workup before they see you for an aneurysm?
Well, there's really no particular workup. You're talking about somebody who was incidentally
Incidental
diagnosed.
finding, yeah.
And it really, I would like to see this patient so that we could capture them, so that we could direct them in further treatment. Because it would be best for them to be evaluated by specialists, and then, if they come to me, I would, evaluate the size of the aneurysm, the location, anterior circulation, posterior circulation. If it's a truly incidental headache, because sometimes headaches can be a manifestation of an instability of the vessel wall. Like somebody who never had headaches and now has a very irregularly shaped aneurysm, and with risk factors, high blood pressure and family history, then this patient might be a candidate for some kind of treatment, and then we can triage it from there. And generally, we have a very close communication. We just, I would just call the endovascular colleague if the patient comes to me, and the vascular colleague will call, us. And we have a luxury of that they already would perform the angiography, and then we come with the 3D images, and then this is a surgical candidate. But if the patient comes to me, I will have to call the endovascular colleague. But it's regardless, it would be best to send them directly to the specialized physician who could just take it from there.
Perfect. Thank you, Dr. Sporer. For those patients referred to you by tremors, let's say from primary care office, how many of those people do you see that really maybe have Parkinson's and weren't worked up or evaluated for that? And then what do you do?
I see a lot of patients, like I said in the talk, that self-refer for the procedure. I try to do a pre-screening, actually. So we'll call them before their appointment, and I'll ask a few quick questions. Essential tremor is pretty easy to diagnose, in my opinion. That's why I don't need a movement disorders neurologist involved in that. And that's a long history, a strong family history. It's 50% inherited, and it gets better with alcohol, and the tremor is worse with activity, not with rest. And so there's exceptions to all of those things, but if they say yes to all of those things, then it's essential tremor, and I'm happy to see them, and we can discuss the various treatment options. If somebody says, well, actually it's a resting tremor, and my voice has changed, and my handwriting's really small, and moving slower, then that's obviously suspicious for Parkinson's disease. I see those patients too, but they would be best served by seeing a movement disorders neurologist first. And luckily, we now have a bevy of them here, 3 different movement disorders neurologists who can do the much more complex workup of those patients. The thing is, for Parkinson's patients, they're often not referred to neurosurgery because the drugs for Parkinson's have gotten so good that they're often managed medically. But for a subset of them who have good benefit but have frequent motor fluctuations and have to take the medications often, they're good candidates for deep brain stimulation, and in some cases, even the high-intensity focused ultrasound.
Thank you. And for Dr. Bander, on the neuroblade technique, how accurate is it for protecting the surrounding tissues when you're doing that?
Yeah, so similarly to what Dr. Sporer was mentioning for HIFU, we're accurately measuring the temperature throughout the brain at the same time as we're ablating the tissue using MR thermography. So it's very similar to HIFU, except for the fact that we have to use a laser that's placed inside the brain to achieve the ablation.
And so side effects are very...
Side effects are minimal.
Minimal?
Again, we can see similar swelling issues
Right.
immediately after the surgery, but over time we see that decrease.
Right, but you don't have that dry run that he has.
No, but these patients already have a tumor, so it's the indication is a little bit
It's
clearer
a little
than
different,
necessarily.
right? A little different, right. Questions from the audience? Yes, sir.
Dr. Tolchin, thank you so much, team, for the presentation. And Dr. Dabus, we worked together before there was an MNI, and many here don't know that we were the first Joint Commission accredited comprehensive stroke program in Miami. And
That's
so
correct.
coming from that, I would like to lead on to, you've seen the whole picture, not that we're older, but if each one of you can talk about how important it was, or what is the difference between working solo. I remember when Dr. Sporer came on board also, and Dr. Seelman, and there wasn't this whole, even though we worked as a team, everybody always worked like a team, but the whole team approach that you now have at MNI, if you can start with stroke, how that helped us as an organization.
Yeah, no, it's a great point to make, Dr. Ribas. So basically, yeah, we're the first comprehensive strokes, JACO accredited comprehensive stroke center in Miami. We got our accreditation in 2014. We're actually the second place in Florida to get comprehensive stroke center accreditation. The first one was Mayo Clinic in Jacksonville. And like I think I'm the oldest one here at Baptist on the present. I've been here for like 15 years. And, throughout my whole career here, as part of MCVI and MNI, which is really the intersection of both, we really were able to create the stroke program. And of course, we started getting more organized after Dr. De Los Rios, who's the stroke director, actually came on board and really pushed the envelope to create a pretty well-oiled machine. I mean, I think we're all very proud of our stroke program. Our stroke program, I'm the president-elect of my national society. I mean, I interact with people in Washington, in here in Tallahassee for policy questions. And I can tell you our stroke program is second to none in the country. I mean, I think we're so efficient and we really provide what is the best treatment options for patients in a very quick way. And I think our results prove that. And I think, it's something that we're very proud of. And, it's something that we're glad to continue to grow. I mean, our stroke program continues to grow. There's a lot of people joining us. There's more stroke neurologists now doing that work. And that also create a lot of, it's very important to have this collaborative approach because the stroke is truly not a single man show. It's really, you require a system of care that's extremely efficient and very, very well connected to make sure those patients receive the best treatment available.
What about other programs in MNI?
Well, for movement disorders, obviously, it's super important that we have a movement disorders neurologist, a whole army of nurse practitioners who are doing this intense workup and management of the patients, including inpatient evaluations of patients, and then the correct referrals to neurosurgery. And then just, I don't only do this, I do general neurosurgery as well, and I can tell you that everybody on stage, we are constantly in communication. And so even if I don't have the solution, I can find that solution in one of my partners or colleagues in 2 minutes. And I don't know if that exists everywhere, but certainly there is a level of collegiality here that I haven't seen in other institutions. So it's just a very pleasant working atmosphere, but it happens to benefit our patients as well.
I couldn't agree with that more. Having been here 12 years and having been in practice for 30, these 12 years of a team approach that we have here at Baptist have been second to none. I can call up any of these gentlemen on stage at any instant and ask a question. I can call up neuroradiology and ask a question. I could call my ER colleagues and send someone quickly. We have a team approach here, and with MNI, our Neuroscience Institute, it's grown to the point where we have 42 physicians who work so well together. I don't know if it's something in the pineapple juice or what, but this is a very unique institution in so many ways, and it's the camaraderie and the level of expertise that you've seen here this morning is just beyond comparison. And I'm so thankful for it. I know that the others on the stage, my colleagues, my partners are as well. There's just nothing that I've seen that compares to it down in Southeast Florida or in the region. Thank you all.